and welcome back to TIA. Okay, thank you for joining us this morning. Schools are back in, and so are we. Okay, it's exciting. There's a lot of education going on, and we're very, very busy. This is the 8th session of TIA, and we have another 2 outstanding speakers. They've both been part of TIA before, and you've always asked me to bring them back. So here they are again. We have Dr. Bobby Baig and Dr. Taheri. They're both prosthodontists. They're like one is in the US. I think Bobby's here, but he's also in Rochester today. And Mo, where are you, Mo? Nebraska?
Today I'm in Denver, but I'm based
Colorado.
out of Chicago.
Okay. But he's moved back to Chicago, and that's where he works from. And now lucky we are that we have such good friends that are willing to come in and give us the best education from all over the world. It's unbelievable. Like one thing that I'm most proud of is this, the fact that we're able to build such a network. Okay. If you guys don't know me, I'm Tori, and I am super excited to be here with you guys. I love these things. Today is a special day because we have, it's really an exclusive that belongs to Shaw, which has become, it's become the largest lab component in Canada. Okay, like with the acquisition of ProTech and Shaw ProTech, this is the largest, like a lab in Canada, and I think they have over 400 employees. So this is something to be recognized with, even at the world level. Such a large lab. So I would like to thank Shaw and Procter & Gamble. They always come in, but they want to do the draw, so we'll do the draw at half time. Okay. I want to do a few reminders because, like I said, school is back in session. There's a lot of courses going on. We have a CBCT scan, how to read the radiographs next week with Dr. Leah El-Matni. She's coming up from Georgia. And this course is good for technicians and jurists and dentists, of course. How do they read, how to read these things and simplify. We have the Crown and Bridge course with Dr. Taheri and Dr. Bobby Baig. That is on October 29th, which is the day after Spectrum Day Toronto. I will talk about Spectrum Day in a second. We have a perio course with Dr. Parvane Barami. We have the veneer course has evolved into 2 veneer courses. There is my Crown and Bridge treatments for the new age. Okay, this is October 29th. There's the theory goes on October 26th, virtual. It's an evening, and then on the 29th they can focus only on the hands-on. Okay, so we wanted to focus more on the hands-on, so we restructure. So you get the theory on the 26th. And then on the 29th, it's full day hands-on course. It's a really exciting course. Okay, so the veneer course has expanded. In fact, we have the veneer course with Dr. Ed Philip, which is world renowned, and then he will do the ceramic. And then we have a course on veneers, composite veneers, with Dr. F.R.C.D. He comes from Tehran University. Okay, and again, he's a KOL for Ivoclar. We also have the endo course with Dr. Farzad Danesh. We have a PRF course. Now, one of the new things that Spectrum Day Toronto, and I'll talk with, we're going to release the program this afternoon. Okay, it's free. There's free admission, free parking, free cocktail, free partying. Okay, and there's also one course that is free but allows in only 75 dentists for Core 1 course. You need to register, okay? And if you don't register, you're gonna be penalized, okay? So you're gonna give us your credit card. We're not gonna charge, but you cannot just say you're coming and then you're not coming, because there's gonna be a huge demand once they see that it's a free course, okay? So it's a Core 1 course. You need the points, okay? And so you're gonna get them with us. And if it works next year at Spectrum Day, I will do 5 of them, okay? So the TIA will continue. Our next course is going to be September 30th, and we have Dr. Gom. Okay, he's sold out. I have a Gom course at Spectrum Day Toronto. He's got 45 people in there, 18 years of this stuff. I love it. Okay, but he's getting a little bit older, Larry, but he still has it. He's got the shtick. We also launched on a successful course online, MIT Mentorship Implant Training. That's online and on demand. You can take the course anytime you want. You can review it, okay? And then you're like, I mean, they're gonna be hands-on live, okay? Right now we're doing it on models, and the hands-on can be either Nobel or Straumann Neodent. You choose, we deliver. Okay, there are dates that are spoken for. You come in, and the speakers there, you know, like my partners in this project are Dr. Leslie David, Dr. Scott McLean, and Dr. Abby Chalamet. Okay, so now on this one over here, guys, every Tuesday or Wednesday evening, next week is Wednesday, we have what we call a power hour, okay, for members only. But if you want to see what it's all about, please call my office and I will let you in on Wednesday night. So basically the power hour is, you know, either Dr. David, Dr. McLean, or Abby, they bring cases, they discuss, but our members also bring their cases. It's 1 hour, it's fast paced, it's very, very good. If you're interested, please let us know and I'll let you in. You are muted, okay? So please turn your video off because it's distracting to the speaker. And the webinar will be available on demand after the live session, okay? If you have a question for the speaker, leave it to the end. I will ask, hey, we're almost finished. Can you please answer the question? I'm going really fast. Before I introduce Mo, I want to see what Shauna has to say about Shah. What's going on? Other they're growing and growing and growing, Shauna.
Good morning, Ettore, and thank you so much for having myself part of this presentation. We definitely appreciate being teamed up with Tia. My name's Shauna, and I've been with Shaw for 21 years. I'm their territory manager. I do a lot of the GTA all the way to Montreal. If anybody's out there in our area, by all means, my email will be at the end, and give me a call or drop me a line, and we can discuss any lab concerns or that you have. Basically, Shaw Lab's been in business for over 77 years. We are a full Canadian company, fully digital, fully service. We have 4 locations in the GTA, Kingston, London, and Ottawa. At the bottom here, you'll see that our email to Perfect Smile Aligners as well. We do have our own brand. We have an orthodontist on site that does personal treatment planning with you. These are our 4 locations: Ottawa, London, Kingston, and GTA. If anybody's looking to rent space to host courses, our GTA location is state of the art, and we've got tons of room. We hold courses there on a weekly basis, so we'd be happy to provide that for if a dentist wants to come in and meet with a small group and teach anything. We have that capability. Definitely, we are a recognized leader in the implant restorative category. Teaming up with ProTech, I would say we are the leader in the lab industry across Canada. If you're interested in doing a lab tour, just use your camera on your phone, and that QR code will be captured. Also, to let anybody know, if you have scanners in your office, we do offer a $20 reduced fee for all scans that are sent to us. If you're thinking about purchasing a scanner down the road, please reach out to us. We have a ton of knowledge about it. We work with all scanners, and we might actually be offering something coming up in the next few months with a scanner company for dentists to do a trial offer at minimum cost. So I look forward to seeing you guys on break, and at break I'll let you know what we're doing for continuing education coming up.
Thank you, Shauna. Like, guys, I vouch for this. I've been at the lab. It is truly beautiful, and they go out of their way. Like, we do the perio course, and Ali, who's the face of Shaw, said, you know, well, why don't you do it here? You know, like, and I said, well, you know, like, we have pig jaws, and you know, you got to put them in the fridge because it's a 3-day course. So guess what he did? He went to my fridge. So he goes, hey, I got a couple of fridges here. I'm gonna put your name on it, but please, you know, blah, 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 blah. So they go out of their way to please, and it's a service oriented. Now let's go to the star of the day, one of them, Dr. Mo Taheri. I'm looking at your bio, and I guess it has to be changed, but let me a little bit, because you're back now in the US, Mo. And this one over here says you moved back to Toronto. in 2015, but you can talk to that later. So Dr. Taheri studied in Toronto and in Boston. He got his Bachelor of Science, Human Biology at University of Toronto in 2001. And then he received his DMD at Tufts University in 2005. That's in Boston. And then he spent 1 year at general practice residency in Newark, New Jersey. And after practicing there for 2 years, Dr. Taheri decided to return to Tufts to pursue a specialty training in prosthodontics. He became board certified by the American Prosthodontics in 2011. He moved back to Toronto in 2015. He received a fellowship with the Royal College of Dentists in 2016. And now he's back in Chicago. Okay, he's working out of Chicago, but he'll tell you more if he wants to about this one. When he finished his prosthodontic training, he was invited to be a clinical instructor at Tufts University in the division of graduate and postgraduate prosthodontics. And during his time there, he developed a didactic course on occlusion, as well as assisting the department with board preparation. I have begged them, to come up with a course on occlusion, and I think next year, in 2023, might be the year where we are going to do this thing. Okay. He was involved with the Massachusetts Dental Society in an effort to develop a new district in Boston. He's a fellow of the Greater New York Academy of Prosthodontics, very prestigious academy, a fellow of the American College of Prosthodontics, and a fellow of the Royal College of Dentists of Canada. He's in 2017, he was also an examiner for the Royal College of Dentists of Canada in the specialty of prosthodontics. He lectures internationally and nationally, and on topics including treatment planning, occlusion, aesthetic, and implant dentistry. And we are very lucky to have him here today as a return speaker. Mo, it's all yours.
Thank you, Ettore. This is very kind of you to invite me here. And just for the audience, Dr. Baig was supposed to go first. And then kind of last minute, he and I talked, and then he let me go first. I'm in Denver right now at a conference of all things, and I'm lecturing out of my hotel room, and this is kind of a first for me, so it's a bit fun. And it's 7 a.m. here, so just bear with me. I'm awake, I'm ready to go. Just it's my time zones are all shifted. I got here last night. So we're going to talk about occlusion today. It's typically a very, very boring topic, and I'm excited to see if I can make this a little bit more interesting. I am based out of Chicago. We're basically running an implant center there. It's a chain called Clear Choice, and I'm the lead prosthodontist in the Chicago center. And every day I see things that failures, successes, I see things that a lot of times can be boiled down to the occlusion. Interestingly enough, when I practiced as a general dentist for a few years, and before I went to do my pros training, and as general dentists, typically the occlusion is tap, tap, tap. Does it feel high? No. Is it good? Good. Let them go. With pros, with complex dentistry, it's a lot more involved than that, because it's not just about the tap, tap, tap. It's about the glide. It's about the grind. It's about how are these teeth going to hold up over the next 15, 20, 30 years? And we all know occlusion isn't a static thing. It looks great on an articulator, but it changes over time. Teeth shift, teeth wear, contacts wear, teeth migrate. And so what you have today is not necessarily what you're going to have 10 years from now, 15 years from now, 20 years from now. But that's getting ahead of myself. When we talk about occlusion, I think it's very important to give a nod to where occlusion came from. And occlusion is not a new thing. The idea of anterior guidance, group function is not new. occlusion came about because of dentures. And the idea was, how did we stabilize dentures 100 years ago, 60 years ago, 70 years ago? This stuff came around in the 1920s, 1930s, 1940s, 1950s. It's not new. And one of the things that dentists and prosthodontists, not prosthodontists, but dentists, because there's no prosthodontists back prior to the 1950s, 1960s, was this idea that if the teeth weren't set up properly, the dentures would be out of quote unquote balance, meaning the patient, and remember, back in those days, dentures were the reconstructive dentistry. That was the way. There was no, full arch fixed implants. There was no, 28 crowns and developing occlusion that way in the 1920s and 1930s. At least it wasn't common anyway. So everybody was figuring out how to make dentures work. Lower dentures were still a problem, were a problem back then. Even upper dentures were a problem back then. And the idea was that if the clinician could develop something called bilaterally balanced occlusion, they could stabilize their dentures. What is bilaterally balanced occlusion? Bilaterally balanced occlusion is teeth that were in full contact in all excursive movements, meaning in protrusive movements, the posterior teeth maintained contact. And all of this was a design to prevent the dentures from moving. In addition, it was a way to organize denture setups. So it gave the goal, and it really set afire this idea of tooth forms. Every time you do a denture and you see the choice to set up 10-degree teeth, 22-degree, 20-degree teeth, 30-degree teeth, 33-degree teeth, flat teeth, 15-degree teeth. All of these ideas are 50, 60, 70 years old. And all of them came about as a way to harmonize the tooth setup with, interestingly enough, the condyles and the condylar inclination, the way the joint moves. And so, one of the challenges we face and we're still, I don't do bilaterally balanced dentistry, the bilaterally balanced occlusion when I do my dentures, but I had to for my board exams in the US. It is very difficult to do because what you have on the articulator and what you have in the mouth are two very, very, very different things. But it really led to this explosion of this idea of occlusion as a science and occlusion as a research topic. So on one hand, you had the idea that there was basically two pathways in occlusion. One was making instrumentation that was as anatomically accurate as possible, and one was using the mouth as your articulator. So on one hand, there was a lot of research on how to make articulators more and more complex, how to make them match the way the stomatognathic system works. And on the other hand was Dr. Meyer, who said, why are we going through all this? Let's use the mouth. And he developed something called a functionally generated pathway, where the mouth replaces the articulator. And this is very interesting because what he did was he basically took excursive movements in the mouth and used these to grind pathways in the teeth so that you could develop this balanced occlusion, or even group function, because it was later used in fixed prosthodontics. and it avoided this whole idea of, do we need to have accurate instrumentation? So there was two different schools of thought. This basically set two different schools of thought in motion, and there were two big ones. On one hand, you had McCullum, Stallard, and Stewart. B.B. McCullum was an orthodontist, and then Stallard and Stewart were dentists, general dentists, because at the time, again, there was no prosthodontists. And then on the other hand, you had Schuyler, Pankey, and Mann. And Pankey is a very, very popular name in dentistry today because of the Pankey Institute. Lindsay Pankey was a brilliant dentist. All six of these dentists were brilliant, but all in their own way. McCullum, Stallard, and Stewart were focused on instrumentation, making their articulators more complex, match the mouth. This is what led to the development of the fully adjustable articulator. The Stewart articulator is what it was called. And the thing was a beast. On the other hand, you had Schuyler, Pankey, and Mann, who really adopted the functionally generated pathway and said, listen, let's do it in the mouth. Let's get it as close as we can. And for McCullum, Stallard, this is what the function, the Stewart articulator looks like, and that's how they programmed it. This is called a pantograph. And what this did was it measured all the different movements of the mandible in relation to the maxilla, and then they'd grind in the movements into the condyles. It would take hours. When I say hours, it literally would take 3, 4, 5 hours to program this articulator. There are guys now, older prosthodontists who can do it in an hour and a half, but that's an hour and a half of time, 2 hours of time that we don't have anymore to mess around with this stuff. We certainly don't get paid enough to spend 3 hours adjusting an articulator. And why did they go through all this effort? Because in fixed, they were trying to develop bilaterally balanced occlusion. This whole idea of interferences, of cross-arch stability, et cetera, wasn't there back then in the 40s and 50s. And so what they were trying to do was they were trying to get the teeth to be in contact in all excursive and basically reproduce this idea of this denture occlusion. But what happened? They had a subset of patients who developed periodontal breakdown, who developed mandibular dyskinesia, meaning they could find a comfortable position to occlude. Occlusal hypervigilance, meaning these patients became very aware of their occlusion to the point where every little thing would set them off, would trigger discomfort or irritation. And to a lesser extent, chronic bruxism. These patients would start grinding their teeth. And so what happened with that? This is the reason we don't want interferences, cross-arch interferences. We don't want working side or balancing side interferences because of this stuff. And in particular, the periodontal breakdown. In those days, periodontitis was a big problem. They didn't have the microbiological background they needed to understand that periodontitis was a bacterial disease. They thought it was occlusion. So this led to a shift, and then in addition to that, TMJ pain. This led to a gentleman by the name of D'Amico who said, there's something going on here. He looked at dry skulls. He looked at them in two groups. He looked at the pre-modern diet native skulls, and found that they had group function with some wear in the canines. And then he looked at the modern diet native skulls and noticed that the posteriors weren't as worn, the canines weren't as worn, and these people, these skulls had cuspid guidance. This is where canine guidance came from. And when did this happen? This was in the, I believe in the early 50s. So canine guidance isn't a new thing. The gnathologist, Stewart, Stallard, McCullum, jumped on this idea. Pankey Mann, at this point, was still doing group function. Schuyler, Clyde Schuyler was a big advocate of group function, and they loved the functionally generated pathway that Meyer had developed. So they were using this in everybody. And in their minds, group function was the way to go. And the functionally generated pathway was the easiest way to get there. Whereas gnathology was doing bilaterally balanced and running into those issues that I'd already mentioned. Both of these groups looked at D'Amico's research and said, you know what, that makes the most sense and it's easy. Hence canine guidance. So interestingly enough, because of the two different groups, it led to this transition of occlusion from a tool to a dogma. And we still see this today. You know, you have people who go to Dawson, who go to Pankey, who go to LVI, and they are spouting out occlusion as if, oh, you didn't go to Dawson? Oh, you don't understand occlusion. You're not doing it the right way. And occlusion is not a dogma. It is a tool. It is how we organize reconstructive dentistry. And we're going to spend some real time going over what that means and how we're going to do that. But it went from being like, how do we achieve our goals, to what is the quote unquote right way to restore a case? What's the right way? But that doesn't exist. There is no hard science that backs up most of occlusion. And today, you know, everything is evidence-based. There's not a lot of evidence in occlusion. So what did these leaders, these pioneers of occlusion argue about? Tooth morphology, articulators, hinge axis, centric relation. So what's tooth morphology? Really, literally, the shape of teeth, whether they were anatomic or not. How complex the articulators had to be. Why aren't you using a Stewart articulator? Why aren't you using a fully adjustable articulator? Why are you using a Hanau? Why are you using a whip mix? Why are you using something super simple? Hinge axis. Are you using an ear bow, or are you actually finding where the hinge of the jaw is? If you're not finding where the hinge of the jaw is, you're definitely not good enough to be doing reconstructive dentistry. This is the arguments these pioneers and their disciples made. And we still hear it today. We still hear it today. Definitely not as bad. Thankfully, dentistry has evolved from arguing about occlusion now to arguing about immediate load, implants. And then lastly is centric relation. What is centric relation? Is it important? When do we need to use it? You know, what is that position? And there's been arguments over the last 60, 70 years about centric relation and its bearing in dentistry. Thankfully, that argument has more or less been laid to rest, and we'll talk about what centric relation is. So to get in very briefly, these were the pioneers of various tooth morphologies. The arguments were anatomic versus non-anatomic, balanced versus non-balanced, meaning cross-arch or non-cross-arch, cusp versus monoplane. When it came to face bows, it was this idea of whether to use the transverse hinge axis, the actual hinge axis, or an arbitrary position like an ear bow. But the reality is biology is not mechanical. You cannot truly determine where the hinge axis is. Frankly, this idea that the mandible rotates is in pure rotation for the first, 20 millimeters, 30 millimeters of movement is false. It doesn't actually exist in nature. You can force it to if you sit there and you crank on someone's jaw, but that's not how muscles work. That's not how biology works. And there's no evidence that increasing the complexity of your articulation of your treatment modality yields better clinical results. In fact, I'd argue that increased complexity inhibits better clinical results because there's a lot more opportunity to make error. So what have we learned in 100 years of occlusion? We've learned that the blueprints matter. Planning matters. The attention to detail before you cut teeth, that matters. So how do we do that? What do we do? Well, it starts with well-mounted study casts in a treatment position, whether it's centric relation, whether it's intercuspal position, but something that's accurately registered. It means that, you know, we need to have some way to relate the aesthetic plane to our laboratory technicians so that they have the aesthetic plane in front of them, whether that's using a Cois bow, or an ear bow, or you know, some way to relate the anterior teeth to the interpupillary plane. So when I say ear bow or face bow, these are two different things. An ear bow is something that relates the maxilla to an estimated hinge axis, basically using the external auditory meatus. And it's primarily used to develop a functional outcome. The problem is with using the external auditory meatus is that it may not be parallel to the aesthetic plane. And if it's not parallel to the aesthetic plane, you could end up with a canted occlusion. It may be very functional, but it'll be canted. The face bow, on the other hand, uses facial landmarks. And today I almost exclusively use a Cois bow for my mounting of my maxillary cast, because we've learned that reconstructive dentistry starts with aesthetics, and form follows function. So if you get the aesthetics right, you're already on your way to being in the right place for function. I will tell you, if it's not aesthetic and it's not functional, you failed. It has to be both those things. If it's functional and it's not aesthetic, you haven't done the patient any good. So we talk about treatment positions. We talk about centric relation versus maximal intercuspal position or habitual occlusion. When do we use those? Centric relation, this idea of having the mandible in a repeatable position, is important when you don't have occlusal reference points. If you're prepping a full arch, if you're doing a full arch of implants, you've lost your reference points. That's when we need to use centric relation. And these are a few different ways of registering centric relation. Centric relation is this idea of reproducing a mandibular position. Can you reproduce maximal intercuspation position? Absolutely. Can you do it if you cut all the teeth? No, you've lost all reference. Maximal intercuspal position is a tooth-derived reference position. Centric relation is a joint-derived reference position. So what are the properties of an ideal treatment occlusal position? I've already referred to the stability and the reproducibility, but it has to be, sometimes our treatment plans take a year and a half to accomplish, especially if we're doing implant dentistry. It has to be stable during the course of treatment. So if you take it today, and then you take this position, you have a treatment position tomorrow, they should be identical or very, very close. It has to be repeatable. So if you take 3 bite registrations, they should be the same. It should be easy to do. It shouldn't take you sitting on the patient's mandible to create this jaw position. It should be, you should be able to record it accurately with PVS or with wax, however you choose to do it. And lastly, and probably the most important, is it has to be comfortable for the patient. I've done quite a few full mouth, full arch cases, quite a few. And early as a prosthodontist, I was very dogmatic about centric relation, and to the point where I would ignore patients who complained that it wasn't comfortable. And what happened? Never mind the discomfort. These poor patients couldn't occlude because they found it too uncomfortable to go back into that retruded position. And it was typically class 2 patients who had a class 2 malocclusion. And so they would posture their mandible forward. And when you posture the mandible forward, all you end up doing is hitting your anterior teeth because the posteriors start to separate. And I kept wondering why patients were coming back with, a 0.5 millimeter gap in the posterior. It was because they weren't comfortable and they didn't want to be restored in that position. So I had to determine an alternate treatment position that still followed these criteria. And that became much more challenging. So what I've learned over the years is when I'm recording centric relation, I'm recording a relaxed position that is comfortable for the patient. It's not a forced position. So centric relation should never be forced. So I'm going to gloss over this because it is a historical perspective and that's not really the focus of my lecture. But centric relation has evolved over the years. And this idea of, initially it was based on a swallowing position of the mandible. And then it was based on what was called the rearmost, uppermost, midmost position of the condyles. And these were forced positions. Boucher said the most posterior position. Ash said it was the midmost, uppermost position. So you can understand why there's so much confusion about what centric relation is. And, some less than charitable folk have used that confusion as a way of pushing their treatment positions and capitalizing on this idea that there's confusion. The fact of the matter is we're not confused anymore. Centric relation is defined by Peter Dawson, as the most anterior superior position of the condyle. It is a relaxed position, and it is not a forced position, and it is independent of the teeth. You can't determine centric relation if the teeth are touching. There's too much noise from the nervous system. The minute a posterior tooth touches, the mandible deflects. That's why when we're taking centric relation, it has to be an open mandible position. You have to take it slightly open. If you recall in one of my previous slides, let me back up a second here. This looks like an NTI device, but really the NTI is based on the idea of using what's called an anterior jig to separate the teeth and record an unstrained but non-interfered position of the mandible. And so you squirt bite registration back there, and now you have your centric relation position because you don't have any interference and any noise coming from the teeth. This is a leaf gauge, same idea. You stick 3 or 4 of them between the teeth and then register a very small gap, but that's how you register an unstrained, uninterfered centric relation position. So skipping ahead back to where we were. So requirements. We need to record the horizontal and vertical relation of the mandible to the maxilla. It needs to be equal pressure in all areas. The record has to be maintained so that it doesn't distort until the casts have been mounted, which is why wax is not a good medium. PVS is a fantastic medium, bite registration material we use. They used to use zinc oxide eugenol. But the most important thing is the recording medium should not resist forces. You shouldn't create deflection of the mandible because the material is too thick, which is why PVS is fantastic. It's why we use AluWax when we're doing dentures, or we used to anyways. So how do I register centric relation? I use a bit of GC pattern resin. I make it takes 3 minutes to make an anterior jig that separates the teeth, and then I squirt some PVS in the back, have them bite in a repeatable position. The benefit of using this quote unquote anterior jig is that you can actually take some articulating paper, have them tap 5-6 times and see, is it the same spot each time? So you know it's repeatable. The other thing you can do, and what I used to do in residency to verify, was I would take 3 bite registrations and I'd mount with one and then I'd check the other 2. Is it coincidental? Is it the same? It should be identical. Some guys still do that. And when I'm not sure I'm in the centric relation, I will do that, clinically now. So reconstructive dentistry, like I said, has evolved. It used to be posterior first. Gnatologists started with the back and then, as an afterthought, created their anterior guidance to separate everything. But we don't do that anymore. We start in the front. Occlusion starts with phonetic and aesthetic ideals, and then the function follows the aesthetics and phonetics. Why is phonetics important? Phonetics are important because if a patient is lisping, if a patient is whistling, if a patient has difficulty with their F sounds, with their S sounds, then you know there's something not right with your treatment position, with your vertical dimension of occlusion, with your anterior tooth relationship. You have to correct that first prior to moving on to the posterior teeth. Some people can't tolerate a huge amount of vertical and horizontal overlap. Some people need almost like a class 3 relationship in order to make their sounds, their speech sounds. Pound in 1976 developed this landmark idea of using the S sound to set up a denture on in the bottom. And it was how you would determine whether a patient was a class 1, class 2, or class 3 skeletal relationship without, doing a Ceph or something like that. And you would use wax rims first, and then you'd set up some teeth and have the patient count from 60 to 70 and see, is there a lisp? Is there a whistle? Are they able to accommodate the tooth position? If not, do we have to make changes? Interestingly enough, the same thing applies in fixed prosthodontics. I use S sound every day. I do a lot of implant reconstructions right now, full arch, full mouth implant reconstructions. And full mouth, full arch implant reconstructions are basically dentures. So we've kind of gone in a circle where we started at dentures. Then, the fixed prosthodontics guys kind of poo-pooed dentures and said, oh, it's not real dentistry. And, that went on for quite some time. And now with full arch, full mouth implant reconstructions, we're back to dentures again, back to the same denture concepts. And so there's still doing a denture setup to evaluate S sounds, to evaluate phonetics. Then comes this idea of the envelope of function. And the envelope of function is the functional movement of the mandible. It's not It's not, it's not mystery. It's not voodoo. It's this idea that there's a certain amount of curvature in the anterior teeth that fundamentally allows the mandible to function. And anterior teeth are concave, not convex. So I see a lot of, redos, a lot of failed dentistry. And often one of the things I see is central incisors or anterior teeth with crowns on them, where there's a big fat concavity on the palatal surface of the anterior teeth. Why has that happened? That happens because of two reasons. One, under prepping your anterior teeth when you're making a crown. And it's very typical of like the PFM days. So now with EMAX and zirconia restorations, but back in the PFM days, it was very common. The second reason we saw it was in class 2 patients trying to establish anterior guidance in a class 2 patient. You'd fatten up the cingulum area to get contact with the lower teeth. The problem is this becomes an interference when the patient is trying to speak, and may not reflect in the sound, but it does reflect in the way the mandible moves. And it creates almost an avoidance pattern, an avoidance of the mandible to not bang into that spot. If it bangs, what you start to see is fremitus, and then ultimately tooth migration. You start to see teeth open up, diastemas form. And you may say, oh, this doesn't really happen. I've seen it happen many times. I'll have patients come in and say, hey, doc, my dentist did these crowns 10 years ago, 5 years ago, and the teeth were together. The teeth were the same length. But now I have all these gaps forming. And then I'll look, and sure enough, there's a violation of this quote unquote envelope of function. The crowns are over contoured on the palate, and it doesn't have to be a lot. So in the anterior, we typically develop the envelope of function by evaluating the S sound, having them count from 60 to 70. Pay attention to the way patients speak. In the posterior, it's the chewing motion. And it's influenced not just by the palatal contours of your canines in particular, but also the degree of occlusal anatomy of the molars. And the lazy reconstructive dentist will create flat posterior teeth. But the reason we go through all these exercises of priming our articulators, of taking a face bow and all that, is so that we don't have to program to have flat occlusal anatomy in the posterior. We want occlusal anatomy because good intercuspation allows patients to feel like they have a solid occlusion. Oops, sorry. So then you get into this idea of the aesthetic plane. This is a denture patient. I know this is a course about fixed prosthodontics, but it's so hard today to talk about fixed, occlusion without talking about removable. But in this case, this was a denture that was finished maybe a year prior. And the patient came to me and said, I'm not crazy about this denture, but I can't put my finger on why it doesn't look good. And it's the idea that teeth follow an aesthetic, a curvature. It's this idea that there is something called the aesthetic occlusal plane, and it's typically related to the interpupillary plane. So when we're developing our function, we're looking at the functional envelope that I already mentioned, the envelope of function. We're looking at parafunctional management, and we're looking at proprioceptive feedbacks and chewing motion. And so we use our provisionals, to map all of this stuff out. I do so much work in my provisionals. I'm looking at, the incisal guidance. I'm looking at the posterior intercuspation. I'm looking at centric relation. I'm looking at vertical dimension of occlusion. I'm looking at the other stuff, gingival health, periodontal health. I'm looking at endodontic health. But provisionals give us so much information. Now, I'm not telling you patients need to be in provisionals for 6 months to test things out. You don't need that much time. You need a month, maybe 2 at most. But you do need to give the patient some time to develop adaptation, especially if you're changing vertical dimension of occlusion, especially if you're rearranging the anterior teeth. And often we are, because if you look, that patient started like this with severe occlusal wear. She was a very heavy bruxer, and very heavy bruxers tend to lose their incisal guidance, tend to lose their reference because of the amount of wear. And then what you end up with is with over eruption of the mandibular anterior segment, because these teeth want to develop contact. And you end up with this almost like dual plane of occlusion. So how do I start with reconstructing these patients? Again, with the anteriors. I develop the ideal anterior wax up. The anterior wax up sets the vertical relation, vertical dimension of occlusion. It's not arbitrary. We don't tell the lab, oh, can you open up the vertical 3 millimeters? No, you tell them, wax up your anterior teeth to ideal proportion. Then set up the posterior teeth. Sometimes aesthetically, this doesn't work. And then you have to look at, crown lengthening, stuff like that. If there's been compensatory eruption of the anterior teeth due to the parafunction, then you're not opening vertical dimension. Then you're working from the gingival side. And then we process that into provisionals, and we have the patient, rock those provisionals for a month, see how they're doing, see how much wear. So I've alluded to incisal guidance. Incisal guidance today is so important. We don't need to program our articulators fully, because in patients who have good incisal guidance, we don't need to worry about posterior tooth contact, posterior tooth interferences. Why is incisal guidance important? The most important reason is to protect the posterior teeth from eccentric or lateral forces. That means immediate separation in excursive movements. Second, anterior tooth contact leads to reduced EMG activity in the muscles of mastication. And when I say anterior tooth contact, I mean the incisors. Canines in this regard actually act very similar to posterior teeth, in that if canines are in contact, you get almost like a clamping force. But incisal guidance in protrusion actually reduces the level of muscle activity, and indirectly may limit the effect of bruxism. It's so important for speech, making S sounds, making ch sounds. And lastly, but certainly not least, is shearing of the food bolus. That's how we tear our food. It's how we don't grind our food in the anteriors. And this is one of the main reasons why you see, when patients are missing posterior teeth, their anterior teeth wear down so much, because they're not just shearing, they're also grinding their teeth with their grinding their food with their anterior teeth. And it's why replacing posterior dentition is so important to having a functional occlusion. So how do we determine our incisal edge position? There's a number of ways. We can determine it anatomically using denture concepts. We can determine it aesthetically, which is typically how I do it. I start with aesthetics, and then I use functional to back up my aesthetic position. So if it's aesthetic and it's functional, you win. If it's aesthetic and not functional, you lose. If it's functional and not aesthetic, you lose. So it has to be both of these things. And to a lesser degree, you can use cephalometrics, but I don't do that. I mean, I believe Spear Group talks about it a little bit, but it's not practical. Most of us don't have a Ceph machine, and we're not going to be doing tracings. So the functional ideals, Panky Man, and this is another big argument that was going on in occlusion, was this idea of how much anterior tooth contact should we have. So Panky Man, the Panky group, they talk about something called long centric, and they want in centric relation the anterior teeth to be in contact. Whereas the pathology group, and this is where I tend to how I practice, I don't want my incisors in full contact. That doesn't mean I want an open anterior bite. It means that I want, when patients tap their teeth together, I don't want any fremitus in the anterior teeth. I don't want any vibration in that anterior teeth. So I leave, if you've ever used artist foil or shim stock or very, very, very thin articulating paper, I want that paper to resist slightly pull, but not hold. But I want those contacts to immediately pick up when there's any kind of excursive movement. So I don't want any posterior contact in any excursive protrusion or working side or non-working side movements. But long centric, from a practical purpose, is probably a little bit easier to develop. So we're going to spend a bit of time talking about that. So first, you establish your centric relation with no posterior interferences, meaning there's even and full contact across the arch. Then you have the patient sit upright, and then you check again in the anterior. There is very well-founded research that shows that the mandibular posture changes when patients are lying back versus sitting up. That's why you always have to check your occlusion sitting up. And when they sit up, the mandible protrudes very slightly, but you're creating an interference in the anterior. That's where you're going to have excessive anterior tooth contact. So the Panky Man, the Dawson group, they relieve that and create this shelf on the cingulum that accounts for that difference in posture. It's typically about 0.5 millimeter. This is called long centric. So either you leave a slight bit of opening in the anterior, and when I say slight, I mean very slight, 8 microns, 10 microns, 15 microns, no more than that. Or you account for this postural variation in mandibular movement. We're going to talk very briefly on occlusal relationships. Today, the go-to is cusp to fossa. It's easy to do. You have one cusp in one fossa. Schematically, looks like this. This is what Dawson teaches. The Dawson group teaches. It's easy to develop. You don't need overly complex occlusion. Historically, the idea was to use tripod contacts, having 3 contacts for every cusp. But it's not practical. They call this the ABC contact. The problem is if you lose this contact, the middle one, you start getting deflections. It's so difficult to do. So what are the occlusal schemes that we have in our disposal today? We have really 2. We have canine guidance, or this idea of mutually protected occlusion. And that's in centric relation, the posteriors take the brunt of the load. In excursive relationships, the anteriors take the brunt of the load, meaning the anteriors protect the posteriors from excursives. The posteriors protect the anteriors from centric. Group function, on the other hand, is all the teeth bear the brunt on the one side, the brunt of excursive contacts. When is this an important use? First off, the problem with group function is that the EMG studies show that posterior and premolar contact can increase EMG activity in muscles of mastication. So you're potentially increasing the risk of parafunction. Secondly, it's actually very difficult to do. It sounds easy, but it's not. You could have a little too much guidance on the cusp. You may have contact everywhere, because remember, we have PDLs. When you have PDLs, teeth shift a little bit. But you could have a little too much contact here and create an interference without even realizing it, because your articulating paper is showing contact all the way around. So it's a bit challenging to accomplish. When is it important to use? Heavy class 2 div 1 patients who don't have intrinsically an anterior incisal guidance. Patients with no horizontal overlap. So class 3 occlusal relationships. That's not a bad place to do it either if you can't develop incisal guidance. The other time, and it's not as intuitive, but it makes sense, is patients with periodontally involved or structurally compromised anterior teeth. A lot of root canals, a lot of bone loss. They want to spread the load a little bit. So how much incisal guidance is necessary? The answer is, and it's a cheap answer, it depends. It's not which is correct, is which situation is each one correct? And it really depends on the patient. Is the patient a class 1? Is the patient a class 3? Is the patient a class 2? You don't override that malocclusion. You can't make up skeletal issues dentally. So when we're talking about clinical tools to develop incisal guidance, we look at muscle release. Is the patient able, or are they feeling locked in? Fremitus, is there vibrations in these teeth? Speech, is it interfering? We look at provisional restorations. Do the provisionals have cement washout? Are they constantly falling out in the anterior? So we develop our guidance based on the starting position, how much freedom in centric, where that incisal edge position we've chosen, and how much curvature that we need for the envelopal function. You've created your anterior tooth position with 4 easy steps. I'm belaboring incisal guidance because incisal guidance is really the key to developing a sound occlusion. So I'm actually going to skip ahead a little bit to the cases. Let's get a little bit more practical. And we have, about 10 minutes before we get into the question and answer period, and I want to be able to answer questions. So case 1, 49-year-old female, no medical issues. Her chief complaint is a worn dentition. And as you can see, she shows teeth. She has, there is a framework here for aesthetics, but she has this almost, excessive overlap. So we're looking at this from 3 different factors. We're looking at it aesthetically, we're looking at it restoratively, and we're looking at it periodontally. Periodontally, she's generally sound. There is some attached tissue, she's missing some attached tissue, so she needs some connective tissue grafts. Restoratively, she's been heavily restored. There's severe wear. Aesthetically, it's deficient. She's got teeth that are different colors. The arrangement isn't sound. And you can see these teeth are heavily restored. They're beat up. Her guidance is severely worn out. It's very steep. You can look how much separation there is in the posterior. So she has fairly steep condylar guidance and excessive incisal guidance. You can see how much wear, especially on these 3 incisors. Teeth have migrated. These diastemas have opened up. And you can see that again here. There's uneven separation. One side has more separation than the other. You can see the guidance has worn through the teeth. And again, heavily restored. Almost have pulp exposures on these anterior teeth. Very sensitive, very uncomfortable. And, failing endodontics. Big post. This was not an easy case. So when I'm interviewing a patient for the first time, I'm trying to figure out, can I satisfy the patient's chief complaint with a limited treatment plan, or do I have to go comprehensive, full arch, full mouth? Is there an ethical responsibility to satisfy the clinical standard? Should I be doing limited dentistry instead of full arch? Should I be doing full arch instead of limited? Should I be extracting everything and doing an all on 4, all on 5, all on 6? What's the right answer? And that's a question that that plagues us every day. But you know, in the end, we do what we think is right. Is there adequate restorative space without altering the vertical dimension of occlusion? How will the worn dentition affect the guidance? If it's too worn, is the guidance flattened out? Is the guidance too steep? If it's too steep, what's happening? Is it causing, you know, periodontal issues? If it's too flat, are the posterior teeth breaking down? If I open the vertical dimension, can the patient adapt to that new vertical dimension? How do I know? How do we test this out? The simple answer is you test it out with a removable appliance, because if you put them in a removable appliance, at least you haven't done anything irreversible. But removable appliances have limited use. Patients don't like it, they can take it out. They're not confined. There's no drive to adapt. Whereas if you provisionalize the patient, do a full arch or full mouth provisionals, the patient has to try to adapt because there's no going back. You've already cut down the teeth. The problem is that puts you in a bit of a bind, because if the patient can't adapt, you've already cut down 28 teeth. How will bruxism impact our material choice? Because bruxism is a big reason we do these big reconstructive cases. Does bruxism affect how many crowns I do? Am I more likely to do fewer crowns or more crowns because of bruxism? Can I protect the dentition with my incisal guidance? That's why we're doing this. It's not just to restore the teeth to their original form and function, but to reintroduce protective mechanisms, guidance, as we call it. What's the long-term prognosis? Can we stop bruxism occlusally? No, of course we can't. Bruxism is a centrally mediated phenomenon. It happens in the brain. It's not something you can turn on or off. It's one of those things that impacts a good amount of 60% of patients at some point in their life. So we have to manage the bruxism. How can the case fail? You always got to ask yourself that question before you pick up a handpiece. How can this fail? Where will it fail? Is it going to fail endodontically? Is it going to fail periodontally? Is it going to fail due to caries? Are there tools to identify or improve our long-term outcome that we can verify? That means, are you tracking your cases? Are you tracking, I tell a patient, oh yeah, this case has 97% success. Yeah, maybe in the literature. In my hands, is it 97%? Is it 90%? Is it 80%? We owe our patients the best treatment we can provide. But we also owe them a referral if we can't provide high-level outcomes. I don't take on big implant surgeries because I can't provide long-term outcomes. I can provide long-term outcomes with reconstructive dentistry. I've been trained to do that. And then lastly, can we achieve the outcome that the patient would like to accomplish? So in this case, I've used a removable splint to raise the vertical dimension and see how the patient adapted. She had some minor TMD symptoms prior to starting. This actually relieved them a little bit, so I knew I was on the right track with raising the vertical dimension. So I took an open bite centric relation, add a new vertical dimension, and we waxed the case. From that, wax up went into provisionals, provisionalized the patient, and tested her phonetics, tested her function, checked for cement washout. Was my incisal guidance too steep? Tested the aesthetic outcome. Is the patient happy with this? No, it's a little too yellow, so we went lighter. So here's the preparations. Ended up having to do a lot of root canals, and I don't do these anymore, these big honking gold posts. This was back over 10 years ago, 15 years ago almost. And where is this case going to fail? If it fails, it's going to fail due to probably one of these root canals. Good news is I still keep in touch with this. She's a friend, so she reaches out every once in a while. I talk to her. These restorations, the final restorations, are still going strong, 10 years later. So fortunately, nothing has failed yet, but we got to keep track. So how do we take the information that we've derived from the provisionals and transfer it to the lab? We use something called a cross-mounting procedure, where you mount your provisionals and then you mount your preps against your provisionals. This allows the lab to use the provisionals and interchangeably articulate them on the articulator, so that they have all that information. They have the vertical dimension exactly as it is in the provisionals. They have the incisal guidance exactly as it is in the provisionals, and they can reproduce that or come as close as possible to what the intended outcome is. Reconstructive dentistry is all about control. If you can't exercise control, you shouldn't be doing reconstructive dentistry. And this is how you control the case. And this is basically just GC pattern resin. And this is futar. It's a very hard, rigid PVS bite registration material. And these are the final crowns. Now, this is PFM. So this is going back a little bit. And aesthetically, could it be better? Yeah, absolutely. Absolutely. But patient loved it. Patient was thrilled, considering where she started from. Look what we did. We managed to control the separation. The incisal guidance isn't too steep, but there's no interference. When you go from the amount of separation, the overloading of the incisors, to a much more manageable incisal guidance, that's a win. And you can see how much separation. It's all controlled. And there's the final outcome. Second case. This is a case of one of my mentors, Dr. Kenny Malaman, out in Boston. And this is an interesting case because she complains that she can't chew on her back teeth. She has, obvious problems with vertical maxillary excess. There's some periodontal issues. Aesthetically, it's canted. It's not the greatest, set of restorations. Her previous dentist had treated her TMD with a permanent appliance. The problem was it actually created, that's the permanent appliance. You can see it's a metal, cast metal, almost like partial denture, created intrusion or extrusion of the anteriors or intrusion of the posteriors. It's hard to tell which. So she has no posterior tooth contact. That's literally how she occludes, which is why we don't do permanent splints in patients. Patients need to have recovery so that their teeth don't intrude. And you can see the occlusion. So Kenny prepped, Dr. Malaman prepped full arch in order to reconstruct that occlusion. So these are the provisionals. Again, they're still canted also. The central incisor ended up developing a root fracture. And so it was extracted and an implant was placed. Now, Kenny does something interesting. He does what's called a treatment wax to develop the aesthetic. This is actually wax. This is not a provisional. This is his ceramist makes a wax outline. They put it in the mouth over the preps. It's reinforced with some triad. And they use that to assess the aesthetic. And you can see one side is higher up than the other. There's a bit of a cant. They use that to develop phonetics. And then these are the final restorations. Now, Kenny does something called a sequential lateral retrusion, which he uses each tooth anterior discludes the next tooth posterior. So the bicuspid discludes the canine, the molar. First bicuspid discludes the second bi and the molar, and then so on. The canine discludes all of them. This way, sorry, let me go back. This way, if something fractures, if something wears, you know you still have guidance. You still have something discluding. You never end up with a posterior interference. One of the problems we run into is patients who are heavy parafunctioners will wear down their anterior teeth, and then all of a sudden a molar will start picking up contact, and then that creates an interference. And why is an interference bad? Because it creates muscle pain, TMD issues. It creates avoidance patterns. Patients start developing fremitus, start developing pulpitis. So there's a lot of reasons why we don't want balancing interferences. So this is the final outcome. Oh, let me go back. It's a very nice outcome. There's full occlusal contact, good guidance, and the patient was, very happy. So that concludes this odyssey on occlusion. Let's, you can email me at any time if you have any questions or if you want to talk. I tried to condense occlusion into an hour 15. But occlusion, there's so much more to it. There's so many more nuances that we can get into, and I'm happy to answer questions if there are any. So,
hi Mo, it's a Tori.
yes.
I mean, it's really terrific. Okay, I love it. Maybe you don't know, but I do the there are no questions yet, so maybe they'll come out later. Like they can deal with you directly. But I want to make some comments. I like your historical approach to these things, and I do the American Equilibration Society meeting journal, and I also help them to organize their meeting, which they do in Chicago every year. Okay.
Yep. So,
and I love it when you mention the Church of Occlusion, because it is a church.
It is a church.
It is a church. And a lot of the times, when we get behind, like when we have the board meetings, and especially when Pete was alive, okay, when Pete Dustin was alive, I mean, they worshiped him, okay? They worshiped the whole thing. And then when the Pankey was there, I mean, they're praising the masticatory system and they're praying. Oh my God, it is unbelievable, okay? It is unbelievable. But I have some questions, because at the beginning you said, like occlusion came from dentures.
Yep.
So should denturists and removable technicians, be on this thing? And then at the end, you also said, I do so much work on the provision. But would the denturist spend the time, or if they make the dentures, that their prosthodontics spend on a provisional, like if you send it out?
So it's a good question. I don't know what level of training denturists get on occlusion. To be honest with you, I really don't know. And because you remember, most of my career I've been in the US, and then for the last 7 years I was in Toronto. So my experience with denturists was generally fairly limited. I think they should get the training on occlusion. I think it's very important for dentures because really, this idea of balanced occlusion in dentures, was developed to try and improve mandibular denture stability. Now, in a world of implants, it's not as important. If you have an overdenture, it's not as critical. But in conventional dentures, it really does help. There's also the opposing viewpoint that balanced occlusion is, worthless the minute you put food in the mouth. And so, there's a lot of argument. This debate has been going on for 100 years. And I will say that that more knowledge is never harmful. What it does do is breed arguments, certainly, but look at where we are with implants. Look at where we are with aesthetics. Look at where we are with occlusion. All this has developed as a result of these arguments. So I think there's definitely, value in denturists getting the training on occlusion, and I would love to see more involved with provisionals and this idea of occlusion guiding dentures. Yeah, especially as they do more of these conversions with the full arch fixed prosthetics.
Yeah, thank you. Now tell me another thing is that for people to become comfortable in this thing, how long would it take? Like, do you have a hands-on component in your occlusion course?
So I never did a hands-on component. I mean, that's not true. When I was teaching advanced occlusion at Tufts, the hands-on components were more geared towards using technology to measure condylar inclination, to equilibrate casts and mounting casts, and how to determine centric relation and that kind of thing. So yeah, there's absolutely could be a hands-on component here, and I've done it when I was teaching at the university. It's just a question of putting it together. I don't have one put together at this point, so it's something I would need to develop.
I agree. Also, I think you alluded in early in your lecture the fact that the people like the members of the American Equilibration Society, okay, and they get this occlusion education, big time. They always, I saw that they tend to look down towards people that don't have that education, and they're not aware. Yeah, well, you don't understand it because you haven't done this thing. With that in mind, I gotta send a survey, or you guys let me know on the chat, or I'll send a survey. How many of our members would like to have an occlusion course? Because it's necessary. I'm telling you something. I have one of my girls. She came from Albania. Okay, and when you were discussing phonetics, I was gonna bring her here and make it speak to you, because somebody screwed up that bloody thing like you won't believe. And now she was asking me last week, do you think it's an implant problem? I go, I'm not a dentist, phonetically, she needs that help. So stay tuned for that, guys. I'm gonna either send it to Bobby or to you as soon as we gotta help her anyway. So I would like to thank you very much, Mo. I really enjoyed it. I like the fact that you started from the historical perspective and you brought it, to real cases, in the conclusion. So I thank you very much. We'll keep in contact. Absolutely. I remind everybody, guys, that Dr. Taheri and Dr. Baig, we do a Crown and Bridge course. We do it twice a year. I had here it comes again earlier on. Sign up. It's a dynamic course. It's really great. The theory on the Wednesday evening, virtually, and then boom on the Saturday, which will be the day after Spectrum Day. You work all day on the Crown and Bridge component. Anyways, Mo, thank you. Now you can go and take your lectures yourself. Listen to the lectures wherever you are. It's a pleasure seeing you. Congratulations on your new appointment in Chicago.
Thank you.
And I look forward to seeing you live soon again. Thank you. Ciao.
Sorry, there's a question from Dr. Esvobodo. You missed it.
Okay.
Oh.
Well,
Please read it in the chat.
Okay. Okay, here you go. What is the ideal? No, there's a few of them that came in later, I think, Bar. But here you go. You're not going yet. Wait. What is the ideal? What is the ideal occlusal setup for a night guard?
You want to know the truth? The ideal occlusal setup for a night guard is the one that the patient will wear. To be truthful, I've done both. I've done, flat. I've done NTIs. I've done anterior guidance with ramps. I've done just posteriors. I've done all of them. And if I can be 100% honest, I haven't noticed a huge difference. Yes, with an NTI, there's always the risk of intrusion, but I like NTIs. I think patients are more likely to wear them. You just got to make sure that they don't wear them all the time. And in fact, you can do what's called an AMPSA appliance, an anterior midpoint stop appliance, that is like an NTI, but covers the full arch. And those are, I like those a lot. I do those whenever there's, any sign of, primary or secondary occlusal trauma. I'll do those. I'm looking at the comments.
There's
Dr.
one from
Svoboda.
Yeah, there's a comment from Masood Niknejad. He's a gifted
Oh
technician.
yeah, thank you.
Yeah.
That's very kind of you.
Masood said, excellent details, information. Thank you. Yeah, Masood is one of the better technicians in Canada, I would say, if not the world. He's a real gifted guy and a friend. So I am biased, but he is great. And then Dr. Emil Svoboda is also very well known. And he says, it's a comment, it's not a question. I was interested in your statement that what you see on the articulator is way different than what you experience in the mouth. That is indeed true. So I guess he's agreeing to with your statement. That's what he's doing.
We've all done it. And I've played with fully adjustable articulators. I've played with semi-adjustable articulators. I have a fully adjustable articulator in my office that, it's gathering dust, but I have one. And I've programmed it. I've spent hours and I go, it's ready. I have it. It's perfectly set up. It's accurate. Then I go to the mouth. Oh, God damn it. It's still different. And so, biology can't be reproduced mechanically. We can come close. And I suggest everyone strive to develop as much accuracy as possible, but you have to test it in the mouth. It's the most important thing.
Thank you. One more compliment from Ani Shanuda, who is a longtime standing member. Very informative, detailed lecture. I think we have something here. I think we should work on it. I'm trying to sell you more, but anyways, I gotta let you go. Okay. And we're gonna go now. First, we go back to Shauna. Okay. I thank Dr. Taheri and Shauna. What are you selling now? What are you giving us?
I am back.
Yes.
That was a great lecture, which leads us into me explaining this course that we're actually doing on full arch implant cases. If everybody wants to take their phone, put on their camera, scan the QR code, it'll go into their phone and they can read about it or, register for one of these courses. First of all, we're part of Chrome Guided Smile Canada. And we are one of very few exclusive distributors. If you are doing full arches right now or multiple unit implants, this is a course for you if you want to learn about Chrome. It's offered in Toronto on Friday, October 21st. Dr. Boyce is coming up from the States to speak and present. And we'd love to have anyone that's even looking at, in the future, they want to start implementing this in their practice. It's for general dentists and specialists. The other course we're doing is on our clear aligners, and we are traveling across Ontario, offering it in every location that we have a Shaw Lab: Toronto, Ottawa, Kingston, and London. So if you guys want to introduce aligners to your practice, or you're looking for a Canadian option, something that's a little bit more affordable, one-on-one support, definitely Perfect Smile is for you. So I hope you had enough time to scan the QR codes. If not, reach out to us on our website, email, and we'll be sure to be in touch with you. And we hope that you'll join us at one of these courses.
I want to make a comment. Shauna. I think, looking at the Chrome Guided Smile Canada, I think Protect Dental at the exclusive for this thing in Canada. And
Thank
now, by the way of Shaw becoming, a Shaw Protec lab, like I think you guys own the Canadian rights to this. Okay, so if you want to do these things, you can contact Shauna or Ali Rezai at a Shaw Lab Group and see what they can do for you guys. Anything else, Shauna?
That's it for today.
Are you coming to Spectrum Day Toronto, Shauna, or not?
I will not be there. I will be at the course for the Chrome Guided.
Yes.
In October. We have lots of things going on in the Eastern Ontario courses that I'm attending here. So
yeah.
We're kind of all over the place right now. It's a busy time for everyone.
Yeah, we're gonna bring. I talked to Ali, and we're gonna bring the Crown and Bridge, I think, to Ottawa and a few other courses. He's really interested in that area in Kingston, Ottawa. So we'll do more together. And I would like to thank Shaw and Shauna and Ali for the support that they offer. We'll do, to us.
Yeah,
now,
we appreciate it, and I look forward to listening to Dr. Baig.
Okay. Now, guys, this is, I like to be trusted, and Procter & Gamble really trust me. And I love, Robin Shields. She's not here, so, and they don't pay me to say this. Okay, guys, they don't pay me, but they always give us a gift to do, to draw something. And so, she said, I said, can I just still do the draw? And she said, yes. And so she has given us a water flosser. It's the latest one, okay, that they have. It's very small and slick. And this Procter & Gamble is always on the cutting edge of artificial intelligence. Like, I don't know if you guys have a toothbrush that I owe. It's really unbelievable. Okay, it's just like having a cheerleader on your hand, because if you finish brushing earlier, it will tell you that you still have work to do. Okay, so it is unbelievable. And if you miss something, you can see what area in the mouth you've missed. So that's the IO. And now we have the water flosser. She's agreed. Okay, she's agreed to give us a water flosser. They'll deliver it to your place. And I'm gonna ask Bobby, pick a number from 1 to 92. Just any number. I can't hear you.
Okay, can you hear me now?
Yes, please.
I
Just
said
any number.
55.
Okay, let me look. Okay. I don't know her. I don't think we've ever met her, but the winner is Dr. Mariam Ali. So we're gonna give your name to Robin Shields and Creston Oral B, and then they'll deliver this thing to your place. They'll call you, and then we'll take it from there. So that takes care of that. Now let's go to my friend, Bobby Baig, Mr. Baig, who's a mover and a shaker in many, many things, really unbelievable, always thinking, always full of ideas. I'm excited about this new product that you and your brother are working on it, okay, Bobby, but maybe you can explain a little better. To me, it seems like it's a Zoom on steroids for the dental community. Okay, that's what it is. How you're able to save the cases and communicate. Like, it's unbelievable. Okay, it is unbelievable what you guys are doing. But anyways, Bobby's here today. He's become my go-to guy. Whenever I want talent, I know, and he never, like today, that there's an accident. But he knows I get a little stressed. He goes, "Don't worry, there's an accident. But I will be there." And he was there on time. But I had planned for Mo to step in, so we keep on time. Okay. Let me give you a little bit about Bobby Baig's background. He graduated from H.K.E.S. Dental College in Gulbarga, India. Okay, in 1997. And then he completed his residency at the Government Dental College at the hospital in Hyderabad, in India. Dr. Baig completed the Advanced Education in General Dentistry program and a graduate program in prosthodontic in Eastman Institute of Oral Health in Rochester, New York. He's an associate professor at the University of Rochester in the Department of Dentistry. He also works as a clinical instructor in prosthodontics at Mount Sinai Hospital. And he's an associate at the University of Toronto. but you know what? He's also in private practice at a dental specialty group, you know, in Barrie, and also he has his own practice. So this guy is a workhorse. He just likes to work. That's why he has no time to shave lately, and he hasn't gone to the barber, but it looks good. He looks like a Bollywood movie star. Okay, he's a board certified prosthodontist in Canada and serves as a national examiner for the National Dental Specialty Examination Board. He was awarded a part-time faculty award of excellence for teaching at the universities of Rochester, and he is an international speaker and author. His topics, you know, the topics of his choice that he loves to talk about is really vast. Okay, aesthetic, implant, reconstructive, fixed, removable prosthodontic, dental ceramic, and smile makeover procedures. The only thing I can say is, you know, he's a special man, and I'm glad that he's our friend. He's a friend of Tia. Okay. By the way, guys, before I turn it over to him, a reminder that next year, you know, like a Tia, we're gonna go and we're gonna have an hybrid component. Okay. But the only thing I can tell you right now is the interest in Tia for next year is huge. There's, you know, like there's some companies wanting to have 6 and 7 days, which I will not do because we have to give space to everybody. Okay. But there's a lot of interest for companies that I didn't even know existed, like NDI, W&H. There's a lot of companies that want to come in. Right now, what we have is we have 2 live, the first one and the last one. When we do the live, we will stream it across Canada because now people come from across Canada. Okay. Like right now, you see there are 91 participants, but there's going to be at least 20, 25 that will ask for the on-demand. So, and the other thing is, that way, it allows me to bring speakers from all over the world like we usually do. In fact, you know, we have, like I said, we have a few more sections. On September 30th, we have Dr. Gom. On October 21st, we have another heavyweight, Dr. Isaac Barzilay and Dr. Barami. And then we have, are you ready for this? Then we have Friday, November 4th, Leslie David. And then we're going to finish up and going to Italy and Saudi Arabia. We have Dr. Silvio Mario Meloni from Italy, talking about vertical guide bone regeneration, etc. And then we go to Dr. Sam Omar, macro versus micro planning. Okay. And Dr. Omar was voted as the best lecture presentation in one of the courses that they did in Sardinia, Italy, just recently in June. So you know what? By doing it, you know, like the blend, okay, the hybrid, it will still allow me to bring some of the big heavyweights. So we got from the global level. So we have North American talent, local talent like Dr. Bobby Baig. I need your help, Bobby, too, you know, to structure this thing. And then, you know, I mean, also the international. We're able to connect with international talent, and it's to your benefit. Okay, so I'm going to turn it over to Bobby Baig. Again, I would like to thank Shaw. They're a great supporter. And now to Mr. Dr. Baig. Yours, Bobby.
Thank you, Tori. It's been a very interesting morning. I hope everybody can hear me. And Tori, by any chance, if you cannot hear me, please come back again and let me know if
We're okay. We're okay,
right?
Bobby. And I will be here. I'm gonna listen. So I'll disappear, but I will be here.
Fantastic. Thank you. So good morning, everybody. As Tori said, today is my teaching day. I'm in the university right now. And sorry, in the morning, I hit into traffic, and Rochester is not a very big city. It's not like Toronto that you're going to stuck forever. So got stuck in the traffic a little bit, but I made it on time. But I'm very happy, actually. Mo did the first lecture because that really helps to kickstart my lecture as well, because occlusion is a very important part of what we do and how we look at things. And again, as Tori mentioned before I jump onto my presentation, I hope most of you are going to be there to the Spectrum meeting on 28th and 29th. On 28th, actually, I'm lecturing on 2 topics. We're actually launching a new technology called Nexus iOS. It's an end-to-end digital technology for full arch reconstruction. This is actually first of its kind technology in North America right now, and it's still not Canadian approved yet, but hopefully they're going to get the approvals in Canada. But I've been already started working in US. So that's the benefit of working in both the countries, because if one is waiting longer than the other for the approvals, at least I can juggle between these two places and still able to get some cases up and running. So it'll be very exciting. Me and myself and Dr. Don Hoy is an oral surgeon. So we are actually tag teaming together with the Nexus iOS team, and that'll be one presentation. Second presentation will be is on nuts and bolts of implant dentistry. These two articles has been published in the past, thanks to Palmieri Group, Ettore. And it's actually pretty interesting articles where we want to have GPs. I think I personally felt every general dentist should have these two articles in their office, because it really simplifies so much what to expect from understanding some very basics of implant dentistry, because I know most of you in this audience are general dentists. So I don't want to take you to the 35,000 cruising altitude of discussing occlusion, because sometimes it can sound very confusing, but I'm very happy Mo really broke down everything into so tiny little bits and pieces. So that's going to be our goal as well in that presentation, in the nuts and bolts of implant dentistry, to help you to understand what to expect about basics about implants and understand the basic parts for different implant systems. So that's going to be the second presentation. Third is the full day, that is Saturday. It's going to be the Crown and Bridge lecture with hands-on. And also on the same day, we came up with a very innovative communication platform called Dental Live. It's called dentallive.com. So we're going to be launching that product in the Spectrum day on 28th. So it's going to be a very interesting tool. I want you all to stop by at the booth and see what you guys think about it. And it's just made by a dentist for the dentist. It's actually I'm one of the creator of the technology, because I always felt that there is a need for more robust communication. So anytime you look at medicine, you have millions of dollars of funding to develop softwares and programs. But when it comes to dentistry, this always takes a backseat. But now I'm glad some companies are moving forward with having the advancements in technology. But this is going to be a very robust communication tool, where that we don't have to spend too much time collecting data and everything. It's all cloud-based, one-stop storage for all your patient care. And if you're seeing things, I can see at the same time. So it's very interesting. So I want you to definitely come and stop by at the Dental Live booth. Okay. So today my presentation is called 10 Beautiful Functional Smile Principles. So we all want to have some great aesthetic treatments with our patients. So I just want to give you a heads up, guys. All these lectures what Ettore organizes, especially on a Friday mornings, these are only some entry-level information for you. So I just wanted to be very honest with you that if you really want to have, see, I'm part of University in the last 12 years. So what I have, the biggest thing what I have seen is having some structured education programs will really help you to take everything to the next level. So Palmieri Group has been very proactive in providing some very structured, hands-on education programs. So these are like teasers for you. So you will see things, but it's going to be very hard to teach everything in an hour and a half. So I just want to make sure that you bring your expectations low, but definitely you're going to see some good information. But this will be something for you to say, you know what, whatever these guys, me and Mo has shown you today, will be some basic entry information. And we will go in greater detail when we're going to see you guys on 29th of October, if you are signing for the Crown and Bridge program, and refine things, you know, because my biggest goal with education is you guys are very smart people. You already know the 90% of doing things. So when we meet in person and do something together, our goal is to take your quality of care from 90 to 99%. We want to bring the 10% change in value of what you do every day. Okay, that's our goal. 90% you already know many things, but the 10% is where when we meet in hands-on programs is we sit down one-on-one, share some ideas, see what are the difficulties you have when you're doing patient care. Listen, I run into issues too. It's not that I'm bulletproof with problems with doing dental treatments. No, it's not. I'm also learning all the time when I meet my senior colleagues or with my residents. So it's an ongoing thing. So definitely when you sign up for this hands-on programs, what Shaw group is also promoting on hands-on in lectures. So these are very, very quality programs, and you'll be very happy. And I promise you, it's going to be well spent money. Okay. Yeah. So let's get into the presentation. So crown and bridge is actually, I always put this slide in the crown lectures because it's bread and butter, guys. This is what you're doing day in, day out. Like it's crown and bridge, fillings, restorations, direct restorations, indirect restorations. This is what really takes your practice to the next level, because you want to be so good in these things because you want to be fast, good, perfectionist, because this is what patients see day in, day out. So that's why today what I do is I want to take you into a journey which is very critical, start to finish, how you look at things and what processing you have to do in your mind when you have a good case in aesthetic zone to see how things can change on a grand scheme of doing treatments. Now, Mo laid a good foundation talking about aesthetics, and also he connected the aesthetics with function. I exactly follow the same principle, because if you have a properly designed anterior guidance, your posterior teeth are well protected. It's called mutually protected occlusion. So that is why I'm glad he emphasized a very important point, that is how you have to look at things, not from back to the front, but is actually anterior to the posteriors. So in this, our journey, we always look at the final outcome, but there is a lot of behind the scenes journey, what not everybody talks about. You go to Instagram, people are posting before and after pictures. I'm sure you do it too. But the most important thing is, you know what happened in the whole process. Between those two pictures, there's a journey. There's a journey where you have spent time designing your prosthetics. You want to see what you're trying to replace here, because patient always comes with an expectations. You know what, Dr. Baig, I want to make some changes in how I look like. So there is a planning, designing, preparation, and final prosthetics, which been given by the lab. And good thing is we have some very amazing lab like Shaw, who has a fantastic network. And I met Ali personally as well. It's a great guy. And I do my every fall, my spring crown and bridge program in their facility. They have a fantastic facility. So there we spend a lot of time trying to understand, take the journey in time to see how we can able to create this amazing restorations. So today my topic will be very simple, 10 beautiful, important points. I'm going to be talking to you exactly like how you look at things, but taking just a little fine tuning some of the information what I can share with you. Okay. So let's talk about all the 10 steps. So step 1, diagnosis, treatment planning principles. Okay. So this is a very, very good starting point. So I'm not going to read all of the 10, but I will slowly, because for me, in the essence of time, I just want to make sure that I be on time. So first thing is what? Diagnosis, treatment planning principles. So obviously, every time you have a patient who walks your practice, you really want to spend a very detailed amount of time understanding the diagnosis, putting a plan together, what exactly initial considerations you have. Because before you make a plan, you always want to make sure that whatever you're proposing has a long-lasting effect. Every time people walk to my office, they're going to ask me, Dr. Baig, how long this is going to last for? They always want to know the durability of restoration. But if you're buying an iPhone 14, which is launched yesterday or today, or Samsung 22, nobody asks this question. They're willing to spend $2,000. They don't care if it goes bad in two years, because they're very ready to invest. But you as a general dentist, charging $1,200 for a single crown, you are expected to last this at least next 10, 15 years. It's not very fair. But guess what? We have no choice. People ask us this question. So for us, prognosis is very critical, because we want to make sure that these things have very good long-term success. But we also have to know when to draw the line, what challenges we need to take on. Because guys, honestly, I'm a prosthodontist by training. I love what I do, but I only take challenges which I can fulfill. I don't want to embrace all the problems in the world. No, thank you. That's the reason we have a massive multidisciplinary team in dentistry, where you can share your cases, talk to them, because everybody's having very specialized skill. So know your strength, know your weakness, know what's the best thing for your patient. So at least you can provide some very long-term care. So when you talk about diagnosis, I'm glad Ettore mentioned this point, because these are the two important things. So probably you're going to have a very specialized speaker coming from Saudi Arabia, explaining macro and the micro phase of dentistry. A lot of times, like for example, if you look at these two classified as two separate things. One is looking at the big picture. Big picture means what? You're looking at a comprehensive assessment of doing treatment. Then you go into the nitty-gritty of doing treatment, the filling, resto, whatever you want to do. But again, what's the big picture? Like, for example, occlusion. Most did spend a lot of time talking about it. Tooth position, periodontal disease. What's this patient up to? I'm doing major treatments. Will he really going to be maintaining these prostheses? So long-term is what is always coming in your mind, okay? And again, we talked about Chrome guided course. Yeah, it's great course. We all need to learn, especially if you really want to do bigger cases, but you will be taught how to maintain this on a long term. So always try to learn how can I maintain this on a long term without complications. Then only you wanted to come into this journey, because post-treatment maintenance is one place where a lot of people don't really spend a lot of time learning how to do it. Okay. Now, macro phases. Localized evaluation, right? You're looking into basically what happening, spaces, what condition of the abutment teeth. If you're looking at even a single implant, there's a lot of planning needs to be done. A lot of groundwork has to be understood when you do this treatment. So every time I have a patient whom I have to really do a treatment, I need to know start to finish what exactly I have to educate myself from a patient standpoint so that I understand their problem. So I want to do medical history, dental examination, obviously full all extraoral, intraoral examination. Then first thing we start is study models. And this gives you a beautiful roadmap. This roadmap really helps you to understand where do you stand. And obviously radiographics are very critical for doing treatments. And that gives you an insight how things are looking from inside. So you're not jumping on saying, oh, I'm going to save this tooth. But sometimes you have to have a thorough radiographic assessment, because before you promise everything, see what's the long-term prognosis. Like if you look at these 3 different radiographs, all these 3 teeth have major issues. So it doesn't matter, it's tooth number 9, because I'm in US right now, so I would say 2-1. Then again, tooth number 1-4, and I'm the second molar in the lower left side, tooth number 3-6. So all these things, yeah, we want to save this, but we know what's going to be the long-term outcome. So radiographs play a very critical role. That's why you want to have more advanced radiography as well. Now, it's not like just you take one X-ray and you make all the treatment decision. Sometimes you really want to invest more radiographic assessment, because as mentioned in mine, because we prosthodontists, we do a lot of comprehensive treatment planning. Nobody sends us for a single crown. If you're sending a single crown, then you need to come to my course. I will teach you how to do a single crown. I promise you, keep that patient in your practice. If you're doing a 3 crowns, keep your patient in your practice. If you're doing a 3-unit bridge, keep your patient in your practice. Come to us, we will teach you, because our treatment is more complex. That's why we have to need more radiographic assessments in thorough detail. So full mouth series, panoramic x-rays, all this gives you a very good insight about findings, caries, cavities, endodontic assessment, bone loss, how much restoration these patients have, direct or indirect restorations. Large endodontic procedures has been performed. If you're planning for implants or any bridge work which has to come off, if implants is the treatment option, where is the sinus position? Where are the critical anatomical structures? Do you see any pathologies in this case? So radiographically, we want to check each and every detail, because you're not just looking at the crown margin and say, oh, there's a leakage, but you want to see what's happening in the other teeth as well. Now, I don't know how often you guys do FMX in your practice, but every time when you refer me a patient, I definitely need these 2 radiographs minimum to be taken. If you guys do it, very happy, take them. If you're referring this case, share it with us. So at least we can help you and minimize the cost of the patient by not charging for these 2 treatment steps. So at least we'll collect the data from you, if you already have in the armamentarium of making treatment decisions. But a lot of people are walking around with different kinds of treatments which has been offered. Guys, I'm telling you, through the whole pandemic, what I have seen dentistry in last 2.5 years, where people couldn't travel, and I couldn't believe, yeah, my practice is only 5 minutes from Pearson Airport. People travel all over the world to get dental treatments. And I've seen so much, which I was very surprised, like, wow, where do these people are getting treatments done from? So thank God we have more structured education programs here. We have a better insight about doing treatment. Like, for example, look at the 2 top radiographs. panoramic X-ray, it's pretty crazy. Like patient has 4 long span bridges, and now this has been there for quite some time, and patient having poor management issues. And if you look at the radiograph on the right side of the screen, you have posterior cantilever prosthetics, and with molar occlusions, like Mo will get a heart attack if you see this radiograph. It's like, oh, wow, I just spent a lecture about occlusion, and look what we're doing with treatment. So at least we have a more structured education programs here. So we need to know which battles we're going to take on, right? So it's very, very critical. That's why if you want to have a thorough understanding. Like for example, on this right-hand screen, this is vertical impacted molar. Now, this patient has secondary caries. Now, these things get very challenging. This is actually referred to me by one of the general dentists. He said, Dr. Baig, what should I do? This molar is so close to the IAN, and this patient has a single crown, and patient has issues, and we don't know what to do because I was told extracting this tooth will be a major issue because that infection can pass on to the third molar. And again, I'm not an oral maxillofacial surgeon to give you training. Probably Dr. Gom will be the best person to answer these questions. But there's a little battle of understanding things. What should we do? So finally, to keep things simple and with a oral surgeon's consultation, the decision was made. Maybe we should endo treat this tooth and delay the eventuality because obviously different sets of skills are there between oral surgeons. So not everybody really want to jump and extract this tooth number 4-8. So the plan was to save this tooth. So a lot of this tiny little details, all you're seeing is single tooth leaking crown, but we are looking at all the other things around as a comprehensive treatment. So that is why radiographic assessment, having a full clinical examination of our cases is very, very important. Now, if you look at these pictures right now, every patient has a different treatment challenges here. So all of them can have aesthetic, periodontal, occlusal, restorative, and endodontic treatments, which has to be taken into consideration. But you always cannot lose the insight about what the patient's main concern is. Yes, we are all trained to do fancy treatments, but never lose the insight. Ask the patient, what's their main problem? How can I help them? When you emphasize on what their main concern is, and you plan things around the chief complaint, I promise you, you make an amazing connection with your patients. So when you identify their problem and try to find a solution, obviously, you know that you are connected to the patient. Now, at that time, you want to make some very important multidisciplinary treatment decisions. Like, is this just a prosthodontic treatment issue, or should I literally have to involve other disciplines? Like, for example, in this all pictures, what you're seeing right now, there is some degree of treatment planning has to be done, not only by yourself, but you have to bring on other specialists also on board. So a lot of times in general dentistry practice is like a one-stop shop, which is okay. And listen, Toronto is a very multicultural diversity, and a lot of times we want to keep everything in-house for many reasons. But sometimes you really want to work with other people. Either they come to your practice, or you can always work with people who are around you, because end of the day, guys, we are here to help you to look better and look good. Okay. And we are here as specialists to bring value in what you do day in, day out. So it's always not going to hurt you. I'm never going to tell my referring doctor that you have to refer me any case, guys. Listen, I teach 50 students every year. I've been doing last 10 years. I made 500 new friends in the last 10 years just coming here and teaching them. So every time they call me and say, hey, Bobby, you know what? I met you, you taught me this, I'm happy. You know, this is where we feel very satisfied. So same thing geographically, if you're in my vicinity of my practice, yeah, bring some cases onto the office. Bobby, I'm going to stop over. I need half an hour of your time. I have a couple of cases. Maybe Dental Live will be that one of the solutions which can help to coordinate and collaborate and just for discussing things on a secure network and platform, right? So providing best solutions, collaboration is very, very critical. Now you already want to go to the next phase of diagnosis. So you want to see what's exactly happening with the patient, how many teeth are missing, what intraocclusal space you have. Like, for example, in this case, you can see, talk about deep bite, occlusal issues, collapse bite. So these cases can be definitely quite challenging. Now, you might have to make major treatment decisions here. Am I changing the vertical? what exactly I'm planning to do here. Are these abutment teeth, if you're doing removable prosthodontics, are these going to be good enough to support a partial denture? And how would I design a partial denture prosthesis? Anyway, that's a separate program, which I also do for partial dentures as a hands-on program. Listen, guys, hands-on programs are the best programs you can learn. They're smaller groups, one-on-one, very interactive. Whatever you learn today, you might forget in 3 weeks. Whatever you learn in a hands-on program, I'm sure Tony agrees with this as well, he will learn for months together. So cases like this, you want to make sure that they have a long-term success, right? So overall, when you look cases from a very comprehensive perspective, you understand the chief complaint of the patient. You have a thorough clinical finding assessment. You know which is going to stay and you know which is going to fail. So that definition and the fine line is very critical. That is your skill. And based on that, you're going to make a fabulous plan for your patients. Now, again, for a single MOD, class 1, class 2, you don't need me. You guys are super trained with those things. But we bring that little 10% of information, what you need to know to take it to the next level. Okay. So now when we have talking about slightly more advanced education in dentistry, like for example, I'm part of the program called Advanced Education in General Dentistry. I still teach in the PROS program, but you are looking at like this presentation is purely one step slightly higher than general dentistry, but you're not a super specialist, but you're not a only basic general dentist, but you are trying to improvise yourself to provide a little bit more advanced treatment. So for example, a missing tooth like this in this aesthetic zone. So you are trying to make a decision-making process like Pontic site issues, what retainers you're gonna do there. Are you planning for a fixed or removable option? How should be a preparation design? And again, these things will be very much thought in detail in the hands-on program. What are the impact of aesthetics on this case? How I'm gonna match aesthetics with this patient? How well I'm able to communicate with my labs? How should be my Pontic design? How much physical space I have? Can I start this treatment today? Or should I wait for some time because it looks like the space is not ideal? What are my treatment options? So even one single tooth can really open up a can of worms with multiple discussions, and slowly a single tooth situation will become a multidisciplinary case. It'll be very funny to know that sometimes I do lectures to my residents here in the department. I bring like a 40 minutes presentation and I end up presenting only like 3-4 slides, and the whole 1 hour is gone, because education is not about volume. Education is about quality. It's not about how many slides I covered in the presentation. How much did you understand is more important for me than how much I covered. So that's why we really wanted to have an emphasis. Sorry, because somebody's knocking my door, I'm just going to tell them that I'm busy. I hope they didn't read the sign. Sorry, guys. Yeah, so when you have a patient like this, obviously, we already know that periodontally, this patient is not very stable. So again, you really want to make an assessment, periodontal aspect of this teeth. So what's going on, and look at the bone loss, vertical, horizontal. Are you trying to save this teeth? And I don't know how many of you can jump on to save these teeth. Definitely, for me as a prosthodontist, this is a full mouth clearance. But again, still on many levels, a lot of people want to hold on to them as long as possible, right? Occlusion. I think this is one topic will keep all the prosthodontists in business for the next 1,000 years. So as long as occlusion is around, guys, we have nothing to worry. So because this is where we come as experts to understand the challenges. Like for example, if you look at here, patient has 3 different patients, okay? Case number 1, the top 4 pictures, this is the patient, the anterior open bite. Because of tongue thrusting and thumb sucking habit. Now look at the plane of occlusion. Now in the same patient already also has crowns. Whoever did the work, they followed the same arc. The arc of doing dentistry, it did not change because they want to follow the occlusion. And I understand the limitations, but this is the case which I'm working on right now. Hopefully by next time, if I get invited by Tori, I'll show you. Actually, Tori, I'm working on writing an article on this case. I'm working with Dr. Leibovitz on this case. how we close 9 millimeters of vertical to get a proper intercuspation. So hopefully this is going to be very
Beautiful. We'll look forward to that, Bobby.
it's coming. You're going to have this case for probably spring to be able to publish in your article. Yeah.
Good.
And in the bottom two is the most cases like patient has posterior open bite. And this patient on the left side of the screen, the bottom, full tooth wear. This is how we get patients into the practice. And we are expected to do miracles. Thank God we have the specialized training because we really want to have a thorough assessment of the patient from a occlusal standpoint, parafunctioning, pathologic occlusion, where exactly the video of this patient has to be, what happens if anything we do as treatments affect the overall. So Mo gave a beautiful insight for you guys. I'm sure you collected a lot of pearls from his presentation. I personally did as well. Okay. Now, once we know from an occlusion standpoint, restorative standpoint, how are we doing treatments? Like, for example, this is a patient with the 2 radiographs. I saw this case, was referred for this implant in the quad 4. Then looking at this crown, I asked the patient, where did you get these crowns done? I said, did you doing like travel dentistry? No, I did in Toronto. I said like, oh, okay. Because radiographically, you can clearly see the crowns are not fitting right. There is no marginal seal. And this is not the dentistry we want to practice. We want to practice much better, robust dentistry and clean dentistry and more effective and long-term and biologically stable dentistry, right? So that's why we want to see restorations which are failing, identify them. If they're large restorations, if the margins are open, fractures, leakages. So these kind of patients can things to the next level. Like, for example, clinically on the right side of the image, what you can see with this patient has fractured teeth because she had a trauma. She was airlifted she was in Calgary doing mountain bike riding. Can you believe she was doing mountain bike riding without a helmet? Trust me, I would never do that. She fell on her bike and she was airlifted from the mountains and she was from Toronto. I got a phone call from the oral surgeon, Bobby, I have to be on board. They did the basic stability. Overall, we're working on this case right now. I stabilized her dental treatments and now we did implants and everything, reconstruction in the anterior maxilla. But again, things is restoratively, are we trying to save these teeth? So the clinical question is, what the long-term? Patient's only like 29 years old. So we know the answer that these teeth can have a lot of challenge on long-term trying to save them. We always want to look into alternate treatment options. So look at this patient. What are we looking at this? We have this patient, a couple of crowns in the anterior maxilla. Look at the severe anterior tooth wear in the mandible. There is a occlusal issues here. Patient has a long span bridge, 3-unit bridge from tooth number 11 to 13. So what are we looking at here? Failing restorations, poor interocclusal space, aging restorations, incisal tooth position. Like look at 2-1, 2-2, 2-3. They don't even match. These teeth are super erupted. Okay. Now, this patient want me to make a bridge on this teeth, the 2 fractured abutment teeth. Now, there is no failure on these teeth. So we want to talk about what's the long-term solutions on this case. So what are we going to talk about this case? We really backtrack. Nobody want to walk around without teeth. Even making a basic entry-level removable denture will be a challenge in this case. Look at the intraocclusal space we have. This patient is going to break everything what you're going to make. If you need to have 2 millimeters of acrylic, if Deepak is here in the presentation group, who teaches in the dentures program, he already knows the answer. I cannot make a reasonable flipper for this patient. So yes, there's one little situation on the right side, but we also running into major issues because a lot of things has to be addressed. So we have to have that open-mindedness when you do treatments with our patient so that we can understand what are the long-term treatment challenges. Like, for example, if you're planning for abutment teeth, look at them. Are these really stable? A periodontal condition, like, for example, look at these crowns, open margins, a lot of black triangular spaces. So biggest challenge for this patient is foot impaction. So yes, because these crowns are leaking, what am I going to do? Just replace these crowns, but still not helping the chief complaint of the patient. You still have to look into occlusal consideration, other old restorations, endodontic status of the teeth. So things becomes more comprehensive, especially when you have more advanced issues like this. So that's why we really need to have a thorough understanding on these issues. Now, cannot miss endo, guys, because endo is a big part of what prosthodontics we do. Like a lot of times, look at this endodontic assessment, right? So we do this all the time. I'm not saying I'm an expert on endo, but definitely when we need it, we do endo test, pulp testing, want to have a thorough understanding of apical pathology because we don't know if these things can be kept or maybe they might need some extraction. So a lot of times, if you look at a radiograph like this, and patient has 2 endodontic teeth, 2 single crowns, obviously you can see one has open margins, you can see clinically and radiographically, and tooth number 2 has some kind of endodontic lesions. There is no clinical relevance here, nothing clinically visible, but radiographically you see. But again, you see the signs, you see the symptoms, you see the radiographic assessment. Now things become more comprehensive. Patient came in for one problem, which is 1-1, but when you take one radiograph, you're seeing a lot of different things. Now, challenge in these cases, what am I replacing? Single central incisor and leaving this aging crown. So how am I going to match the colors? How am I going to tell the Shaw lab to match a new crown should look like an old crown sitting next to an old crown? So I know I'm trying to confuse you, but still you have the patient is not happy to replace all the restorations. So this is where we have to make a decision what challenges we want to take over, right? So that was a very brief entry-level summary about treatment planning. If you want to see the full spectrum, I'll see you on 29th of October. Now, next topic, prognosis and realistic expectations. Same patient. When we took the post out, this is what we have. So patient said, oh, Dr. Baig, can you send me this back on? And I think I should be okay. Okay from what? You can see already clinically, especially the 3 pictures on the front for you, especially 1-1. You already know the answer. This tooth doesn't have the greatest prognosis. So telling the patient, I'll resubmit this post again is only going to help him to buy some time to make some decision. But long-term, this is not what's happening. For definitely, we need to document this, let the patient know, and also make a note in the chart because trust me, the last thing you want to have is college coming after you and asking questions. So documentation is very, very critical, guys. I don't care if I don't do treatment. At least I will make it a point. I write it notes in the chart because tomorrow if somebody questions me, at least I have a proof to show them, you know what, I discussed this, I informed this, I told the patient it's not a long-term solution. It's only going to get some time till make a treatment decision. They do. So we have to able to be very realistic expectations in our cases. Like look at these 3 radiographs on the left side. They have some degree of issue. So if the patient want to save this teeth, you already know the answer. We can't do this. The crowns are failing, but look at the roots. Look at the furcation involvement of the molars. These teeth have no long-term commitment to stay in the mouth. These has to come out. But a lot of time patients want to hold on to them because I'm sorry that most of the time in general dentist practice, it's all about insurance-based dentistry because insurance really dictates and it holds a hand when you're making treatment decisions. So patients always want you to take to the path. Let's go to the path of insurance, but insurance has only so much limitations to cover because the moment you talk about single implant in this case, the first person to leave the room is the insurance company because they don't want to help you because they don't somehow is not unable to process in their mind that implant dentistry is a good prosthetic solution for a single missing tooth situation. They will approve you for a 3-unit bridge. They don't mind you cutting virgin teeth sitting next to that edentulous site, but they will say, oh, implant has too much. Yeah, I understand because a lot of times people don't take structured programs. That's why maybe they're not very ready to embrace implant dentistry. But if you guys are doing structured education programs, what's wrong with them to come back and say, you know what, we're going to help you with this patient. They're willing to give it $3,000 or $2,900 for a 3-unit bridge, but they don't want to compensate that money for an implant crown. Anyway, this is a very debatable topic. We'll when we meet in person, we can chat more about this. Now, sometimes patients come in and say, oh, I have a long span bridge, Dr. Baig. Can you put this back on? I'm traveling, I'm going back home to my home country, then I'll go and get the work done. When he did it, why can't you do it? Okay, because when patients come with this attitude to you, it's going to be very hard to argue with them because they want you to do exactly what was done in the past. A lot of times when you do treatments, one thing I don't like is not tell the patient when you do a redo, don't expect the same expectations. It's not a brand new car, guys. You're trying to refurbish an old car here. You can't expect this to be like 2022 Tesla, you know. Your car is already 10, 15 years old. There's a 15-year-old bridge and you're expecting to cement it back on. Again, you can hit the road. So we are not like the CAA of dentistry, okay? So the thing is, patients always try to push you in through those lines saying, put it back on. I know it's gonna work. But when you look at it, it's barely any ferrule and so much leakage that you're gonna be struggling even to re-cement something like this. So this is where you have to really put your foot and make a decision about, put your foot down and make a decision about how to tell the patient that I'm sorry, that bridge is not going back, even if it's dead for a very short time. Okay. No, from an aesthetic standpoint, probably you might have seen this picture in most presentation is actually his picture slide. So like he showed you a full rehab on this case. So I'm not going to spend more time discussing, but definitely he took a lot of consideration. Chief complaint, anterior teeth were in the bottom. So a lot of things were taken as a factor into treatment. So you really want to know, even if this patient comes, assume this is your patient, not most patient, doctor, just replace my 3 front teeth. But what are we going to do with the bottom? Recently I had a referral, one of the general dentists, he sent me a case. I understand sometimes when you tell them they don't understand, you always want to have your buddy or friend or your colleague to come and tell them because then they sink into their mind. So same thing, two anterior teeth with PFM crowns with the lingual metal, and the lower 3 anteriors are completely like wearing up. Barely there is 3 millimeters of tooth structure remaining. I get a note saying, Dr. Baig, please fabricate crowns in the lower arch. So I already knew the sad story in these 2 lines that unfortunately my colleague tried to explain to this patient that he needs treatment on the maxillary arch too, because the bottom teeth is not going to receive treatment because anything you do on a 3 millimeters, 4 millimeters remaining tooth structure, where are you going to get the core height? How are you going to prep this teeth? By the time you prep, this is gone. So these are the challenge we have to take. Yeah, we're going to change this, but what's happening in the bottom? So we have to look at things outside the box. Okay. So prognosis and realistic expectations are very, very critical. That is why when we see these things, that's why we move on to the next step, which is trying to educate the patient. If anything is missing, what exactly is missing? How much is missing? So we try to do from a digital standpoint or a conventional treatment standpoint. So that's what we're going to talk about as the next topic. Okay. But don't fall asleep, guys. It's going to get more interesting. Okay. Amazing patient. Patient was referred by one of my good referring doctor. Treatments were done in the office. Very young man. And by the way, guys, if you're taking screen pictures, please do not post it on your Facebook or Instagram because for patient's privacy. That's why we didn't mask their eyes because we want to share with you to the real cases. Okay, so this is the patient smile. So first thing, I know you're such a smart people, you're going to say, oh, Bobby, why don't we start with ortho first, right? So obviously that's the first thing that comes in your mind, which is okay. Definitely, I will do the same thing too. So what happened is this is how the patient did, okay? Smile view and retracted smile. You already know an answer that this guy's 6 feet 3 inches tall. Okay. Already he has hypoplastic teeth. The sizes of tooth proportions compared to his height proportions doesn't match. So facial proportions with physical proportions, this is always going to have to sink in your mind when you're doing dentistry. Okay. So if you tell me that this patient didn't go to ortho, of course they did. He underwent orthodontic treatment. So, but at some point we said, we're going to space them evenly and leave it there. So at least I know that I can maximize this, the amount of treatment what's need to be done. So we took models. This is the model's picture for you. You can see how there's a big spaces. Now, spaces have been not very even. Some in spaces like 6 millimeters, some places 5 millimeters. And they tried and tried, but didn't work. So for me as a prosthodontist, I have to create the balance. I cannot have a 4 millimeter space on left side, on the other side is 6 millimeters and try to compensate. That's where it becomes very challenging. That is why we want to have a smile preview of the patient to see what exactly this patient is expecting. For example, this beautiful, wonderful lady, she came in for a treatment. So this is what she's smiling. Tooth number 1 has a dark line. She said, I want to look good. There you go. So we use digital smile design. There are a lot of beautiful, amazing softwares, smile design, Smiley 5. There are a lot of new things. So technology, very easy, click. You have before and after picture. You take one picture, in 5 minutes, you have a ready picture of a smile preview. So patient really like this. So this is where you connect to the patient very easy. Like for example, same thing with this guy. I did the same thing. I said, you know what? Let me do some digital smile design for you. You didn't invest anything yet. Okay, I have the software. I did spend 10, 15 minutes, came up with this beautiful smile design. I showed him, he said like, oh, wow, you know what? This is good. I think we have something to talk about and discuss here. So just a few more cases before I start continuing his case. This is the patient before, the smile design. This is her after, and this is before, and this is after. So when you have this kind of help, and again, I'm sure if you don't have the software, don't stress out. Shaw Lab will help you with, they have a team there. So just send them the pictures or talk to their technicians. They will ask you what pictures to take. Trust me, you can take these pictures from your cell phone too, and still able to send it to them and get some reasonable smiling pictures of the patient. So this is how you're going to connect with your patients, and this will help them to initiate the process of doing treatments with you. Okay. So now once we took the pictures, we want to do more detail like wax up, models. So mounted casts, Mo showed you a lot of mounted casts. He explained to you great details why we need this thing. So I'm just going to skip this slide. Okay. And doing wax up, I'm sure he showed you a lot of information about wax up. Why do we need it? It gives you a blueprint for future treatments. Okay. And many other features, like for example, temporaries or patient education, all these things can be factored. Now, obviously, this was also very thoroughly explained to you from why we need to do face bow. I don't know how many of you are interested in doing it. Mo said he has the Strauss full arch articulating, full pantographic tracing articulator with him. I'll tell him not to sell that because he can save it. And at some point, that's going to be price of a Tesla because everything became antique. You go and try a Rolex watch right now. Trust me, $5,000 watch is like 30 grand right now. I'm sure some of you have tried it to get one. But so things whichever from back in time are becoming more antique. So having these kind of diagnostic steps are really going to help you. So even if you're not doing a fully adjustable articulator, even a simple face bow transfer, simple semi-adjustable articulator, still you get a lot of information. So for example, if you can see in this slide, I'm not going to read out for you, you can understand what are the valuable information you're gathering just by doing a simple face bow. Okay. So that was the aesthetic preview and wax ups. Now, tooth preparation. Now, I'm not going to go in great detail because it's going to take forever. So, but this will be discussed more detailed thoroughly in our hands-on program. So principles of tooth preparation. So when you're prepping teeth, from a basic information standpoint, you want to be very careful. You want to make sure you're not getting too close to the pulp. You want to only prep how much is needed. You want this tooth to last long. So you have to create your retention resistance form. You're prepping on a tooth which is solid, structurally sound, and you're making treatments on top of them, which are going to last for a very long time. And you have a great seal, not like the pictures which I showed you in the previous slide, where you have open margins. And this biologically, your restorations are having a decent dialogue with gums saying that, guys, I'm here, you are here, let's live together. So your restorations are not creating an atmosphere where the biologically you start seeing changes, gingivitis or periodontitis or food impactions, Like for example, in this case, this is my 2-3 unit bridges. So we try to maintain the harmony as much as possible, okay, with our restoration. So we need to know how much to prepare, what restorations are we creating, what kind of tools we need. So either you do a zirconia or a PFM or a cast metal or a monolithic zirconia or a layered zirconia, there are a couple of rules and regulations to follow how much preparations to be done. Those we're going to talk on more details in our hands-on lecture. Now, once you prepare, same gentleman whom you've seen before, I kept preparations very minimal. You might ask, Bobby, why don't you treatment plan this case for crowns? Why did you end up doing veneers? Because some of the spaces were almost like 4 or 5 millimeters. So you don't want to have too much unsupported porcelain on a 29-year-old. But unfortunately, this might sound a little aggressive, but I kept the preparations very simple. You will also see from a contrast standpoint, because you can see the quality of the preps from a black and white to an X-ray picture, color pictures, to see the difference, how we try to keep things simple, not having things very invasive, just preparing restorations so at least they can receive the parallelism of the restoration, the amount of preparation, the margin lines and the finished lines, the gingival retractions, and we're going to talk a little bit more on those lines as well. And we want to make sure that we follow the full proper Schillingberg's rules for tooth preparation. So for example, if you look at all these titles on the left side of the screen, this is what you really have to look into one by one. Doesn't matter if it's a single tooth, full arch, or a 3-unit bridge. You have to follow all these rules and regulations when you do your treatments. Okay, so obviously you can keep them very parallel. You want to make it some degree of taperism, because it depends on how much long span bridge you're trying to create. For example, in here we are making temporary, so we will have some degree of convergence, because patient will have other replacement options in those missing teeth. Okay, so they are very, very critical. Now, when you are prepping teeth, you have to have a good armamentarium to prep your teeth. Like when I came in the department, I have installed 2 important things here. One, the burr blocks. I want to make sure the burr blocks are very perfect. And trust me, I designed them like 10 years back. Even today, they're using the same things here in the university. So these are the most simple, less expensive, ideal. If you have this 2 burr blocks, maybe you can take a picture of this. You can do almost 95% of your crown and bridge and your restorative treatments. So if my 50 residents can do this every day for last 10 years, I mean, we probably modified a little bit as we went with time, but definitely you don't have to invest a lot of time. Every time I see burr blocks, because I did work in GP practice before, you guys have so much on your plate. This is one thing you always keep on the back burner. But when you start streamlining or cleaning a side of dentistry, things get easier and easier and you move faster. Like for example, if you have these blocks, these burrs, you're good. You're good to get the treatments work done, and you can do all treatment restorations except veneers. Obviously, that needs a little bit more advanced tools and techniques, which you're going to be learning from Ed Phillips' course, which is part of Palmeri course as well. So you can look up in the website for that program. But now we are talking about zirconia now. So lately, been 10 years now, I am struggling to work with the restorations because zirconia already started taking over from PFM. So if you go back and use a conventional burr blocks, I'm telling you, you're gonna, if these burr blocks are used to cut zirconia, probably they're gonna go back. That is why we need specialized cutting burrs. So you need specialized zirconia burrs. So it's actually from LHM. I was working with the system for quite some time. They kind of simplified this very simple 3 different burr blocks, the FG1, RAF-G1, RA1. So these are 3 different burr blocks. You can take a picture and look it up, call LHM, and they will help you to answer. So they have very nice structured burr blocks to help you to cut and remove crowns. So those are the intraoral. These are the extraoral with the straight handpiece. Choice is yours. See what you want to use. So this screen, definitely take a picture, guys. This is what you need if you're having a zirconia patient, or if you cannot, you can talk to your Colton reps or your Access Dental or Brasler. It's up to you. Now, see the 2 burrs on the right side with the 2 bands. Those are the ones what you need to remove zirconia crowns. So this is where how they have simplified. I swear to God, I'm telling you, these things cut zirconia like butter. You can take out a zirconia crown in less than 5 minutes. Okay, so these are the burrs which we used into taking them out. Okay, so we talked about tooth principal preparations. Now, we prep the tooth now. Let's talk about temporizations, right? Same thing again, bring back our patient. So our gentlemen, same thing. We have the smiling pictures. So what are the materials we have for tempers? So mostly any practice, these are the 3 different materials which we use in and out. Either you do a PMMA materials made on chair side. You can use a light or jet, your personal choice, depends on how you train. We'll talk about these materials in our hands-on program, and I'll teach you how to do temporaries. And again, in this BIS GMA material like ProTemp or Temp A2, like different companies have their own brand name, but it's all BIS GMA material. And again, this you have to learn how to work with these, because especially these two materials, they have a different speed of working. So you have to really know how many teeth are you doing, how fast you can work with, and it's get a little technique sensitive. And again, now we have the milled blocks as well. So you can scan, mill, and design and do restorations too. So based on the wax step, I made chair side temporaries. But I know that this patient just finished orthodontic treatment and he wants to be put on retainers. He's tired of wearing the fixed braces. So I said, you know what, let me prep and temporize these teeth. These are the chair side temporaries, which I made out of wax up and ProTemp, okay? And then I took impression, because remember a previously picture I showed you, he had packed cards so that I can take the final impression, and I made some lab process temporaries. So these are the lab process temporaries and with this aesthetic. See how we beautifully balance with temporaries, chair side to lab process. The lab has more control. You can design the length, shape, anatomy. So sometimes it's easier to design a computer than design in the patient's mouth. So try to work with your labs if you have a little bit more complicated cases. So just to give you a little preview, these are the before prep, direct temporaries, chair side with ProTemp, and this is the lab process. Now, I kept him for almost 4 to 6 months because he still has slight mobility on his teeth. I even actually saw him this Thursday, yesterday, for a follow-up. And look at biologically how we maintain the beautiful integration. Look at his gums with the temporaries. And if anytime I show this picture to people, they're like, Bobby, are you sure this is temps? This looks like final crowns. Actually, they do, because it all depends on what materials you're asking your lab to mill these things from. And lab have some amazing materials and technicians who can really give you some amazing looking. Now, a lot of times people say that don't make beautiful temporaries because patient never going to come back. I don't have the problem in my practice because I already tell them these are cement with temporary cement, guys. This is going to come out. So don't even think that you're going to leave me and walk away with this, assuming these are your final crowns. I'm sure you all are laughing there because you already know this is what happens all the time. Now look at these two, just to show you a comparison between the lab made temporaries and the chair side. Now, the limitation with chair side temporaries is the color, the shade, because you don't get 10 different colors in shades, especially with the ProTemp or any other chair side temporary material. But lab has a better material selection, so they definitely can help you with that. Okay. Now, but sometimes that's the previous case. Now, the new patient, this patient, what she had, she's a beautiful looking lady. She has already existing over crowns, and this all has to be replaced because she got done in like 10, 12 years back, and she need to look into replacement options. Now, this is where things can get quite challenging. You're already dealing with old crowns. For sure, you will have some degree of leakage, and you don't know what to expect from inside because these are PFM crowns. So radiographically, you can see only the margins, but inside you have no visual what's going on. So what's the first step? Obviously, you're going to make a plan and you start prepping the teeth. So very carefully with your porcelain, with your diamond burrs, you're going to make cuts in the porcelain, use the metal cutting burrs to cut the metal. So you want to gently remove one at a time because you don't know what's inside. So this is what's inside. Now, when you see something like this, and the way how the soft tissues are right now, and the tooth discoloration, the leakage. So it's not a very pleasant visual, what you see of this case, but patient's expecting, Dr. Baig, you need to save all my teeth and give me new smile. So they talk about the new smile, no? So this is just to give a visual about when all the crowns came out. This is the time where you spend time cleaning up the old mess, making it look proper, doing treatments where you're making a beautiful interface between the biological gums and the temporary restoration, what you're going to make, and cleaning up all the failures, what you're seeing in terms of endodontic issues or caries or leakage, discoloration. So then you're working one at a time so that you know that you're going to save as many teeth as possible. So this is what happened with me. From here, I took this patient to this step, cleaned everything, build up my course, build up the pose, refine the margins, and look at how beautiful the gums look right now. Amazingly, because Color-wise, yes, you have zirconia materials and different materials, which we talk later. But from a treatment standpoint, you want this thing to be very stable because you are also relying on this teeth to last under 10, 12 years. So this is what the patient wants to. So this is what we took forward with this patient: preparation, cleanup, post and course temporization, okay, and taking the bite records. Now, Mo already showed you in his presentation how the bite blocks are made, especially when you do a full arch rehab. We really want to work with the right materials. Back in the temporary materials, patient already established the TAMs, we segment them so that we can take the tripoding of the two posterior segments in the anterior. You can see in the picture one, patient has bilateral TAMs, and the front is the anterior teeth with the bite registration, and then these two blocks again as well. Okay, then obviously you wanted to, once you have the lab process TAMs, you're going to reline them. It's very critical. You use jet-like materials or lab process temperatures, whatever your choice. But again, you really know where the margins are. In the previous slide, her margins were off. So actually, it's a different patient, but I'm just showing you for a visual how you mark the margins with the pencil. You start trimming them, especially on your right side, on the upper right side of the screen, where you can only see the pencil mark. So at least you know where to stop when you trim. The pencil has to be sharp. This is the softless disc from 3M. You can use them. This is what we're going to teach you in the hands-on program, how to work with temporaries and how to really make beautiful TAMs. So you want to establish the interface biologically with this patient, same patient, made lab chairside temporaries. This is her before the preps. This is her with the new temporaries. And this is how far she can smile. And now we're trying to understand her smile as well to see how much is clinically visible, because you can see strikingly in her smile that tooth number 11 has a gray band. So we need to see what materials we're going to use to mask these things. Okay. Another patient, just to show you, this is the patient, which is the temporaries. Funny thing is, I finished this case yesterday itself. These are the temporaries of the patient. And this is how I saw the patient for the first time. So you can see the journey between pre-treatment and the treatment. And my next slide will be the crowns I inserted yesterday in the office. So this is her, okay? And you can see the different profile pictures of the smile, and also
I like my smile.
I just took this video for her. I just want to see. It was very funny to record that one-liner. But keep in mind, she's not a 30-year-old lady. She's a 67-year-old patient. She wants one of the best smiles she want to have. And this is what we gave her yesterday from here. This is the before temporaries, and this is the final restoration which I delivered yesterday. Okay, now let's talk about soft tissue management, because now you know you made your temporaries. You are happy with the materials, and you biologically create a good interface between these two. And now let's talk about how would we manage the soft tissues. Now, keep in mind, guys, look at the preps. You spend time making temporaries. How should we be able to record? Because a lot of times we as prosthodontists, very rarely I'm doing single tooth impressions unless it's central incisor. Nobody want to do it. They want to send it to me, which is okay. I'll be very happy to take the challenge. I know how to work with these cases. Or you're talking about full reconstruction of multiple teeth. So if you look at the close-up views, preparation design, packing up the cord, how we are isolating the margins, how we're recording this thing, how are we able to have this clean preparations and ideal margins? How are we able to capture this to educate or to show to the lab? Because anything you make has to look amazingly beautiful, and you should not see any kind of recession when the final restorations come back for a trying. So how do we do this at the time of impression with our patients? Now, what I do is in the practices, a great impression starts with controlling the tissue and the moisture. If you have saliva, bleeding gums, things are not right. Obviously, you didn't get proper marginal capturing the margins properly. So you need to have proper tissue displacement. That's the only time you can able to capture the margin. You have to control the moisture, the blood, and the clear impression, right? That's why what we do is we use periodex. So what I do in the periodex is I give the patients 5 days before I make the final impression, especially in the bigger cases. Trust me, when you take the temporaries out, this is how the gums look like. I'm sure if you all want to have gums looking like this before you made an impression, you cut down your impression time almost to the half of the time. Okay, so that's what you do. Five days before, not 5 weeks, 5 days before with Periodex, 3 times a day. And when you bring the patient back, even if you are cementing veneers, and even at the time of cementation, I also do the same protocol with the patient too. So impression time, 5 days before, cementation time, 5 days before. Now, from impressioning process, we already see here a single cord technique, or you can follow the dual cord technique. Like for example, you can see in this picture, we're making a bridges in the posterior maxillary arch, and again, it's a double cord technique. Cord 1, the smaller diameter. Cord 2 will be the little bit larger diameter. You can just take out one cord and leave the second one, especially when you're packing the second cord, you want us to leave the little extra thread so that when you go back and take it out, you're not digging into the gums to take the first cord out, because a lot of times when you do that, you'll pull the second one in as well. This is like a little tip for you guys to follow. Okay, so it doesn't matter, single crown, multiple crowns, formula is the same. You want to make sure that you isolate well, expose the margin well so the lab can see it. Keep in mind, if you're not seeing the margin, lab technicians are not gods, guys. They cannot see it either. I know they always want to be nice with us and give us a good restoration, but unfortunately, if we can manage the tissues well and get good impressions, you'll have a great restorations coming back from the lab. So retraction, obviously we know either you can use knitted cords or twined cords, choice is yours. Mechanically, epinephrine or aluminum sulfate, choice is yours. There's all options available. Again, size of the cords will help you how much retraction you're looking for. Don't go crazy. Take a probe, measure the probing depth, see what kind of cord you need to pack. Keep in mind, you are talking about aesthetic zone restorations. You cannot gonna be very aggressive. If you detach the biological weight from the tooth, you will start seeing some recession. So be very careful when you pick up the type of the cord. Now, if you're not very much into the cord techniques, people are incorporating the what do you call the tissue management with the retraction material. So 3M has it, Kerr has it. So it's like a retraction paste. This also will help you retraction the cord. Now, because if you're planning for scanning, what you need to do is you have to also maybe take into consideration the fact that you need to pack the cords again. So if you don't like cords, bring them back. If you want to buy a scanner, you need to pack cord. Okay. Next, pink and white aesthetics. So we talked about the cards. Let's see how we can do the balance. Now, if you have restorations in aesthetic zone and you have pontic design issue, this is very, very critical. We want to make sure that we pick the right choice of the pontic. Okay. So what are the most commonly one used is the ovoid pontic. Why? It has broad and flat ridge, can be used create surgically, which I'll show you. Okay. You can sculpt this thing. It's amazing part about this. You can sculpt it and make it easily, creating that beautiful emergence profile. You can floss easily with this thing, and okay, and most commonly used in the aesthetic zone. So for example, if you see here right now, this is the patient who's missing 2 teeth. She doesn't want to do implants. And again, we have very flat ridges there. So we want to create this nice, beautiful ovoid pontic. So there's 2 ways of doing it. Okay. So one technique is we are using laser to create the very minor plasty of the tissue.
We lost the sound, Mo, Bobby.
So,
okay.
Yeah. Now, basically, so what we're trying to show in this picture is you can use lasers. Lasers have been very effective to create the soft tissues, and also you can what you call use your diamond burst to modify. So this is in the bottom picture is what you're seeing right now. This is the after the procedure, and we create a beautiful pontic design of the temporaries and then the final restorations on the right side. Okay, so but when you have bigger and larger cases, if it's not a single situation, things can become a little bit challenging. Like for example, In this patient, she cannot do a dental implant. We forcefully have to do 6-unit bridge in the anterior maxilla. So this is what we have. Okay. And look at how raw these tissues look like, because this is what we make the modification. They're very flat. We use lasers, we use the round burrs, created this nice sculpting of the tissues. This is after the sculpting, so you should know exactly how they are. And because the originally was the ridge labs design temporaries, so we sculpted these tissues, created a nice ovoid pontic on the using composites, so we can go back, and when you place them perfectly in the patient's mouth, this is how things look like after 1 week, 10 days after follow-up. So you can see how beautifully things heal. Look at in the top right picture and look at the bottom picture as well. You see how you can receive these temporaries. So this is how we started before, and this is the after. So fine tissue management with the pontics, especially with lasers and burrs, unless you have to do surgical correction, but fine tuning by yourself. You don't have to work with a surgeon on this. It's very easy, guys. No, there's no rocket science. We'll talk about this more when we meet in our lecturing program in the Spectrum Day. So, but sometimes patients have irritation. Like for example, in this case, I modified the tooth. You can see here I use lasers. There was gingival growth. So we did modification. These are patient temporaries. So we modified things. We're gonna wait for a couple of weeks to see how things are. Then if I have to modify the pontic itself, I will do it. But I just modify the tissues here so that at least we can create a nice zenith and the shape of the gingival margins. Okay, just to show you. And this was purely done using lasers. But a lot of times we also not only relying on basic entry-level treatments, but we also rely on crown lengthening procedures as well. So you can see in this case is a full mouth rehab. This actually worked with a very good surgeon. His name is Don Hoyt. Donna and I work on this case. So on the left side of the screen, this is the patient's how much tooth structure loss has happened. You can clearly say that this case has lost video. If I just go and prep this teeth, there's not going to be enough tooth structure. So now you can see Don did the crown lengthening surgery in the middle pictures, and I raised the video. This is my preparation, made the patient the temporaries. And when you make a decision between gingivectomy and crown lengthening, either it's an osseous surgery, non-osseous surgery, depends purely based on your discussion. In the anterior, you're doing for many reasons, aesthetics, okay? The other reason is for pocket depth reduction. And you want to have a good crown inward ratio because you want to have a good retention resistant form to your crowns. And again, you're creating a customized gingival phenotype. Like for example, in the previous cases you saw, you're creating something for aesthetically pleasing. That's not the patient had. We are creating this to have a better aesthetic outcome. In the posterior, obviously, to lengthen the root trunk, pocket reduction therapies, same thing again, crown root ratios. And if you have any forcations, then you're really treating these things for these two type of procedures. So decision is purely based on what you want to have as an access to do treatments from both of the options between crown lengthening versus the gingivectomy as a treatment choice. Now, next topic, the lab procedures. Obviously, when you have a bigger cases, the treatment steps get added more. Like for example, in the previous patient which I showed you with a full mouth crown lengthening, what we do is I took impression, send to the lab. We had some issues capturing the margins the best way, because keep in mind, a tissues which has been manipulated by crown lengthening surgery, for them to mature, it can take up to 8 to 10 months. But nobody has that kind of patience at least in Toronto. They want to get things going, but you still want to wait 3 months. But you want to have an entry-level impression, get the margins as much as possible. You can send the impressions to the lab. They'll make you this kind of composite copings or GC resin copings. So what you do is you go back, insert them in the patient's mouth. You place a light body material. You'll see it on top of your preps. You can see on the lower right side on the picture, you see that red and the green material, that's actually light body. And I connected them together with composite. On the top picture is what you're seeing right now. These are like the little mini copings. And you can do a pickup impression so the lab have a better tissue management and you can able to record the margin. Anytime you have a bigger cases, sometimes you have to follow these kind of set of treatment protocols. This is just to show you impressions, top and bottom. These are the dye models of the preps. These are your final restorations from the lab. Looks amazing, capture the margin to the best. Everything looks good. And then obviously this is just to show you the top occlusal for the mandibular arch and also the maxillary arch restorations. So it's a full mouth rehab as well. And just to show you radiographically how we have a perfect seal in the patient's mouth. On the upper left side, patient lost one tooth, so Don placed an implant there. So I left the temporary for now. I finished the whole remaining part of the case, left those quad 2 posteriors and the quad 3, there's one molar there, old implant. So we changed the video. You can see that stepping in the occlusal height of the posterior molar compared to the mesial crown 3/6. So you can see that. So once obviously we made temporaries on them. So they're still on an occlusion. So once I make the finals, which is in the process of making right now, then the whole puzzle is complete. Okay. So this is the patient, this before treatment and after giving ideal aesthetics, smile, and beautiful restorations. And again, last two, so obviously cements and cementation techniques. I just wanted to keep this very simple, guys. All the decision process from cementation selection process is purely based on what you're looking for. Are you blocking out the under the restoration? What's the final restoration design you have? What's the material, what you made from a PFM or zirconia material? Like for example, in this case, you can see there's a dark shaded crown, the light color crown, but your ceramic materials are the same. You really have to make a decision what material goes where so that you can really create the masking of the stump shade and also create a good illusion and transition from a color standpoint from your crowns versus to the natural adjacent teeth. So cement selection is a very, very critical process. If you're using PFM, how you do surface treatments with them, with the metal ceramic crown, you can aluminum oxide, steam, clean them with alcohol. If it's zirconia, you can do air abrasion. You can add the MDP monomer, something like Z primer to help you to have a better chemical bonding. Obviously, you know the answer. If it's glass ceramics have been used, there are etchable ceramics. So this is actually a presentation on its own. So I'm just wrapping up in 1 minute. So, but it's a protocol of steps, what you need to follow from etching to hydrofluoric acid to the full 9 yards of doing things. And I also will teach you in the presentation in October, if you're coming there, about what you do's and a lot of don'ts when you do cements and ceramics. Okay. Cements, again, either they are glass ionomer cements or resin modified glass ionomer cements. You guys use it all the time. So there's no new material for you. You guys are thorough with these things. With luting cements, obviously, most important thing is the bonding of the restorations. But again, keep in mind, a lot of times these luting resin cements are filled materials. So sometimes there might be some shrinkage and can really increase the comprehensive strength of the material. Good thing is these are insoluble compared to the other materials. This is very important. And sometimes because of the higher filler content, the material is so thick and viscous. So when you're compressing crowns, you want the material to flow off. So different companies make different consistency in terms of cement materials. Okay. So you really have to know what materials you have in your practice, helping you to make the treatment decisions when you're making the cementation protocol. But finally, the last topic is the how you delivery, post-insertion care and maintenance. Guys, the most important thing is sequencing of treatment is very, very critical. Okay. Your consultation, the records, your referral process, who are you going to work with, or you keep it in office if you have visiting specialists in your practice, presentation to the patient, financial discussions, proper planning with FACP and provisional restorations, preparation and temporization, foundation restoration, which I showed you with my previous cases, how bad we're there. I had to build back all the foundations. Okay, making impression strategies, I talked about that. Insertions of the treatment, the Baig triangle, the final insertions, then fabrication of a night guard, right? So these are very, very critical, like 1 to 10, you're following all these steps because sequencing is very, very critical. Because should be modified as necessary, because keep in mind, you always communicating with the patient. Because now, sometimes the case can be so complex that it's not like a one trying everything fits well. Sometimes you might have to pick up impressions, either to close the black triangular spaces which lab missed out on. Maybe the colors was not right. Maybe the incisal length was not right. So always, if you're being bigger case, tell the patient, you might not get them today. I might just trying to see how things can be. Okay. In the Baig trying, you can do trying material, see how much masking you're able to do with the underlying two structures. Okay. So again, you can club some of the treatment steps in one appointment. It also depends on the size of the case as well. Now, keep in mind, it's very, very critical. Whatever I showed you, it doesn't have to follow it in smaller cases. Generally, we follow this protocol in bigger and larger cases. I would say bigger and larger cases, even a 4 crown, 6 crown is also a big case, guys. You don't have to be a full mouth rehab, okay? So that's what the protocol, what we want to follow. Like that's what the big difference between general dentists and prosthodontists. We are two, I would say, anal about things. Sorry to use that word, but we want to make sure that we don't miss out on anything, okay? Most importantly, finally, guys, long-term prognosis is very critical. Do not promise moon to anybody. It's hard to get and achieve those things. See what the realistic expectation, make sure that these things are long-termly able to manage without any issues. Identify them, because the likely cause of failure before any treatment is started, because if things are not having issues, like for example, the things what you really need to pay attention, something like caries, periodontal disease of the patient has, poor patient compliance. Yeah, this is actually a big factor. A lot of people want to spend a lot of money doing treatments, but mentally they're not ready to maintain things. So that education as a long-term post-treatment is very, very critical. Okay, things can fail, but you need to know what materials you need to pick and choose in your cases. So I know zirconia is not for every patient. You can use other materials too. Do we see mechanical and biological failures? Answer is yes. So what we see is, from a journey standpoint, we want to make sure that anything we give as a final outcome from a treatment, from a start to finish, preparation, temporization, final restoration, before and after treatment, there's a beautiful journey, and following all these trend treatment steps, which are really helping us to get where we need to be. And finally, informed consent, very critical. I always take these things in writing from a patient, discuss about proposed treatment, talk about alternative acceptable for the patient. Doesn't mean that is one option is for all. You know, one size doesn't fit for all. Okay, talk about risk and benefits of doing treatments. What are the longevity expectations of this? Bring the discussion about failures. They already have failures in their mouth. These things can come back. Nothing is bulletproof. I tell the patient, if you have a Mercedes car right now, I see them outside my window, what they came to my office with. You bought it just brand new car, maybe 2 years old. Give 10 years for this car. What's going to happen? That's going to go bad too. So wear and tear is part of life. So we have to tell them things can fail. But if the compliance is good and your post-treatment maintenance is ideal, you as a clinician, the best thing you can do is slow down the process of the failure. You cannot completely stop, but you will help slow down the process. After 5th year, they're okay. They're mentally willing to take the responsibility if things fail. At least you're going to look good with the patients, okay? So these things are very, very critical. I hope my presentation was helpful, guys. And Ettore, thank you. I finished exactly 3 minutes before. I'm sorry if I didn't leave a lot of time for questions. I have my email.
You are
here.
perfect, and I know you gotta go to your class because I know you, Bobby. But I tell you something. I really like it when you present. Your lectures are always informative, educational, and current. Like you show the cases you set yesterday, which is beautiful. I love the idea of a journey, Bobby. I'm gonna give you an idea. I got an article from Italy because we network all over the world, and there's this doctor. He's a prosthodontist in Italy. Okay, who has traced, he's kept track of a girl, a young girl that has started with him, at, she was 12 or 13 with an ortho, okay? And then he goes through her life, and now she's 43, so he must be 66, but he's gone over her life, okay, veneers, cosmetic, problems, perio, everything. He's documented this lady. So you see this girl's pictures from when she was 12 until now. She's, I don't know if she's 48 or 53, I can't remember, and it's about a 60-page article. And I said, man, I gotta serialize it because it's really a beautiful concept, the journey. And you mentioned it, so I wanted to indicate this. Now, guys, you can see Dr. Bobby Baig at Spectrum Day. As I said, he's lecturing with Dr. Dan Hoy, who's a maxillofacial surgeon, and the topic of their lecture at Spectrum Day is, are you still dancing with the verification jig? So next is, oh yes.
Yeah, this is the one. This is the one we're gonna be lecturing on. Next is
okay. Okay. So
the background. There you go.
Success outcome in the success zone will be discussed more Yes, Nexus iOS. Okay, and that's for this is a new this is from Keystone Implants,
Yes,
Bobby?
Keystone end-to-end digital technology, guys. If you guys are doing full arch restoration, please don't miss this lecture. You're gonna love it.
Yeah, you know, like they have a lot of movements at the global level right now, and you know they're led by Kishore, who used to lead Nobel for a long time. He was in charge of Nobel Biocare. So yeah, it's exciting to see. You know, I've had a couple of meetings with Kishore. I think there's going to be some exciting times for these things. What else was I going to say? Basically, I would like to thank you again. You know, we'll bring you back over and over again. I look forward to seeing your article, guys. The Crown and Bridge course again is going to be the 26th. It's about 3 hours, you know, in virtual. And then on the 29th, we're going to have a hands-on, and Dr. Bobby Baig and Dr. Mo Taheri will expand on the concept that he mentioned, you know, today. You know, like they'll go in more detail because they have the whole day in what they discussed today. So to everybody, guys, I wish you a great weekend. Congratulations to Miriam Ali, who won the water flosser. And for the technicians, there are always a few technicians that come in our courses. I look forward to seeing them tomorrow. We have a DTA program. And don't forget the CVCT interpretation course if you are interested in that. And for the doctors, guys, if you want the free Core 1, phone my office. I don't know if you can register yet online, because at Spectrum Day Toronto, that Core 1 course is free. And you know, Bobby, we had to beat up the, you know,
They can.
beautiful. You guys can do it. Go online and register. Now, keep in mind, you know, like, I mean, I was getting, you know, like everything we do is free, Bobby. Like I love to give education. Okay. So you come at Spectrum Day, everything is there. And then I see that the, you know, like, and originally the Core 1 course could not be given for free if you give the course, let's say with Dr. Bobby Baig and charge $149. Those were the rules by the RCDSO.
Yeah.
And then I look at the ASM and they have 18 of these Core 1 courses and they're charging, I think, 49. I said, you know what? You're charging 49. I'm going to start giving it for free. And then next year I'm going to do
$1.49.
I just need space. I just need space. But anyways, guys, have a wonderful
Tim Hortons
weekend.
coffee.
Until next time, you know, I wish you a happy weekend. I would like to thank my beautiful wife. Where is she? For being in the, she's at home working from home, making it
You're
happen.
welcome.
I had to come to work today, Bobby. I'm like you. And
It's my
we'll
pleasure.
see you, brother. Okay. Hey, Mo, no, before you go, you're doing a launch at Spectrum Day Toronto. You bought a booth. Can you quickly tell people what's going on, Bobby?
So that's, as I mentioned, everybody, this is called dentallive.com. So it's actually a dental life planner. It's a collaboration tool for communication. So it's a HIPAA-centric collaboration tool. So it's going to be actually launched on in the Spectrum meeting, and you guys are going to love it. And it's a very click use to talk to your referrals, talk to your own team. You'll be amazed how many features you're going to have. And definitely once we come there, please don't forget to come and visit us at the booth. Okay, please.
Okay.
So
Yeah.
I'm going to share all those great features when you see me in person.
Okay, guys. So have
Thank
a great
you.
weekend. Thank you to everybody. Until next time. Okay. We'll remind you when the next time is. You know, like, I mean, we have Dr. Gum, I think, in the next time, and a business course. We'll talk to you later. Thank you, Mo. Drive safe. Careful. You want to say something?
Yeah, finally, guys, if you have any questions, please, my email is bobbybaig@gmail.com. Feel free to send me an email. I'd be very happy to answer if you have any questions. And thank you all for spending some quality time with us. I hope our presentations and most presentations were helpful to give you some insight about what to expect from aesthetics and occlusion. Okay, you guys have a great.
Thank you, guys. Thanks.
Thank
Ciao.
you. Ciao.